our presentation, let me also move you down. So we'll start with our abstract. So what our presentation was, is we looked at mental health in general. We focused on access and quality to healthcare as our social determinant. And we looked at the resources that JVSU had and the barriers that they still had present in their current system, as well as what they could do to improve. So what we did first was we described social determinants. So what are social determinants? We looked at what affects people and their access to be able to receive proper mental health care. Some things could be race, income, education, location, and what is the problem. So about 75% of people with mental health disorders show signs and symptoms present by the age of 24. And show a range of anxiety disorders, depression, eating. So why does this matter? Mental health causes a lot of later health concerns such as stroke, heart disease, diabetes, asthma, things that can impact them later in life, because depression can include people not being able to go to their jobs, not being able to take care of themselves the way they would if they didn't have mental illness. And we noticed that when we looked at IPE, I'm in public health, Brandon and Adriana are in medical and dentistry. So we were looking at the long-term impacts of students not having mental health access and really just not taking care of themselves, not exercising, not eating healthy foods, which causes cavities and infections. And so we decided to look at what JVSU was providing for their students. So we saw that JVSU was doing pretty good compared to some of the other colleges. They were offering free counseling for a limited amount of time, and then they had a reduced cost. They also had emergency care services. They had a peer education group. They also had a team set up to where students could go to faculty or family and say that they are struggling, and the family could send in referrals. They also have resources at the recreation center where students can exercise. They can really find other services that would improve other aspects of wellness, so physical wellness, social wellness, like the Lanker Link, having social connections and clubs that would help eventually help their mental wellness. Spiritual wellness activities. But we saw that there was a lot of things still missing. So barriers such as stigma, students not wanting to take advantage of some of these opportunities. Also, time is definitely a conflict. Students have very busy lives working and going to classes, so they may not always have time to go out and seek these services. Cost is still a barrier, although there is some free group sessions and free sessions. After that, there is a cost to continue on therapy. And then also limited knowledge to resources. So not knowing what exists and not really being able to find things unless they're looking for them. And then also looking at individuals trying to take care of the problems by themselves or just denying that they have a mental illness altogether. So we found some ways that other universities were trying to solve some of these issues. Wayne State was promoting a single day that they surrounded towards mental health, providing access and information for students. They also did prescription delivery. So if students were getting prescribed different medicines for treating their depression or anxiety, that the campus was allowing them to be free delivery. They were also having nutrition counseling to help students eat better, and the Peer Body Project, so helping women and people of all kinds to understand and love their bodies. Michigan had some interesting projects going on with gender affirmation for trans and non-binary students, and specific depression treatment groups specifically for men. Then there was also dog therapy and just a lot of different great things that we found going on at other universities. So what were our recommendations for JVSU? So for stigma specifically, we found that A lot of people who are facing stigma when it comes to mental health are either male, Asian, international students, or come from a very religious or poor families. So we suggest that JVSU focus and center some of their mental health efforts around different races, different religions, different genders, just to try to include everyone in their services. We've also decided that time was very important. Looking at how they can improve students who are working full-time. So offering online scheduling so students don't have to go in during office hours, call to make an appointment. Also utilizing services such as BetterHelp. So having counselors available 24/7, not just a 5 to 9 schedule for students also that are busy. For costs, we suggested using a schedule program. So incorporating mental health more into a regular schedule of a student. So when students go to their counselors and advisors to set up their course schedule for the semester, they incorporate a single hour that the student recognizes that it is for mental health. And then also increasing their knowledge, that would also increase their knowledge and promote health literacy if students are already registered in these mental health classes. And yeah, so empowerment groups and different things like that. We'll jump to some of the questions though. So this is where we want to get you guys involved. We want to have you guys go into that link, and if you guys have any things that will help you remove barriers, help with the time stigma, that you guys can add your ideas in these little sticky notes. So yeah, go ahead and feel free to do that if you guys have any comments about the programs that I listed, or you guys have any programs of your own.
Great job. Thanks, Emily. Any questions for Emily or her group?
On your link, and it says it's password protected. Do you have a password for that?
Let me see. You should be able to do it now.
It's a good idea. I like that interactive nature. I think it really uses the full capacities of doing this virtually. So that was kind of a cool feature.
You guys should all have access now, but yeah.
You know, maybe what we could do too, Emily, is kind of towards the end, have you put that back up and see what people want to contribute?
Sounds good.
What they've written in. That's a really interesting idea. Any other questions for Emily's group? I think this is a real interesting topic, and certainly one that I think a lot of college campuses are, as you noted, kind of figuring out the best way to offer mental health services, especially during this time. So very great topic. Well, thanks, Emily. And why don't we jump to our next group, which is Team 14, which was Sophia Hadley, Yazelle, Nicholas, and Tiffany. And their project looked at the impact of lower income and underserved population on quality healthcare. So I will turn it over to your group.
Good evening, everyone. How are you? Can you hear me well?
We can.
And is the screen sharing appropriately right now?
Yeah, it looks pretty good. I think just the right-hand side's cut off a little bit, but I'm sure as you shift around, it might work okay.
All right, I'll try to find which window that's in. I think I just have too many windows open.
Tell you what, I could screen share for you. I've got it pulled up if that might work better.
Yeah, I know I have this tab open somewhere, but I can't find it right now.
I'll go ahead and pull it up on my end just a second here.
Excellent, thank you. Oh, wait a minute, I just found it. That's good if you could do it.
Is that looking okay?
I think so. That will be helpful. Okay. Good evening, class and everyone else that's here. Our group did a poster here on the impact of lower income and underserved populations for the quality of healthcare that they have access. So it's really important to properly define the underrepresented community. So we found a 7-point definition strategically considering various categories such as race, ethnicity, geography, and health outcomes. Now, medically underserved communities have a lack of primary care providers and higher infant mortality rates and other things that fall into that region of healthcare. In regards to Michigan specifically, there are over 80 geographic areas that have been identified as medically underserved. Some of the challenges that are faced by these communities are financial instability. As many of you are probably aware, there are many challenges that underserved communities have to face when it comes to seeking healthcare. For instance, financial stability is a huge factor that underserved communities have to deal with. In relation to the government, it seems as if they can only do so much. However, what people are not aware of is that in order to get benefits from the government, you have to be eligible. However, this is not possible due to these communities' incomes volatility. Therefore, this occurring issue within these specific populations remains, even though they are suffering from getting medical help because of their continued lack of financial stability. They also have delayed access to care. Along with the challenge of gaining a sense of financial stability, these communities face the challenge of getting care quickly enough when they need it. This is again because a lot of these communities cannot get any form of help from the government due to their ineligibility, along with their long-term debt. Therefore, these underserved communities keep putting off getting treatment because they can't afford the out-of-pocket costs. However, this kind of action remains a constant battle because it results in patients staying longer in the hospital because they did not get the treatment they needed from the start. And that grows into bigger medical and financial issues. Another thing that we see often in underserved communities is a diet based on food insecurity. Food insecurity being that these communities are often in what's called a food desert. They have access to fast food and convenience stores, but they don't have access to fresh fruits and vegetables or markets that have healthier options for them. It's a problem of food insecurity as well as access to because of the financial instability. They don't have access to adequate nutritious food. And as a result, many of these individuals suffer from obtaining a healthy diet, which is an effect on their overall health, along with expensive medical treatments that grow into the future. Echoing off some of those challenges are the impacts and significance of those challenges. Because individuals in underserved communities face financial challenges and delays in healthcare access, they are more susceptible to develop complications related to the lack of interventions and the lack of treatment. These same individuals are also more likely to present with low health literacy, which shows a terrible kind of irony because these are the communities that need access to both quality healthcare and education. Some novel solutions might require training and understanding and access to technology that not everyone has. Some of the people that live in these underserved populations may not be able to use lower cost telehealth delivery methods that can use technology to help an underserved population. Some of the solutions and improvements that our group identified are extending healthcare coverage. Individuals who are uninsured or underinsured are far less likely to get medical care when they need it, with 73% of respondents stating that they had no regular doctor or usual source of coverage or care. For low-income adults, recent evidence shows that expanding access to public insurance, health insurance, creates positive effects on access to care, healthcare use, financial strain, and their health. Cost-related access problems lead to poor care and delayed care and lack of preventative care. Even adults who have insurance through healthcare have reported much is not covered. Extender and better quality healthcare coverage is a crucial improvement. Another one is the insurance reform. And this is more on things like the Affordable Care Act or introducing single payer coverage. This has been talked about as an option for healthcare coverage, but it's shut down because people want to keep their privatized healthcare insurance. They have fear that quality would diminish if the price isn't high. Doctors might get lazy because they wouldn't have incentives to work as hard. Universal healthcare is another option, and that refers to everyone having some sort of healthcare insurance, but it does not focus on the quality aspect of that healthcare as much. Each reform option improves the affordability of health insurance considerably through lower premiums and cost sharing and broader public program eligibility. Reductions in consumer costs are greatest in the single payer plans, but as affordability increases, the taxes necessary to finance the reforms would increase as well. As you can see, there's an impact on these low-income, underserved populations, and the improvements come with their own challenges as well. Does anyone have questions?
I have a question for you, Nick. I just want to thank you for your presentation. Yeah. It was nice to hear you. Even though you're not in my class this semester, it was nice to hear. My question for you guys, and this could be anyone in your group, as you guys were researching your solutions and those different healthcare reform options, I'm just curious to see what you guys think the best option would be. Since you're the future of healthcare, you know, it's nice to hear your opinions too.
Excuse me. Yeah, I think that's a really good question. Thank you. We have really the healthcare coverage and the insurance reform are sometimes, in my opinion, a really necessary evil almost. Like it's such a complicated program already, the way things run, the intricacies of how our insurance system works. And I know that there are other countries and other areas of the world that do things differently, but America is just such a different place than every other place in the world that implementing something like that really does have to be a long-term goal. It has to be something that we can project far into the future and then make small steps toward. So I think reforming the insurance system that we have, as well as almost from the healthcare side, the way that we approach our patients, the way that we provide treatment for them and think about treatment for them, it would really be helpful for us to have a reform in the way billing works and in the way treatment works and in the way that we view and treat disease as well. I think that maybe that's not a specific enough question or answer to your question, but that's my opinion. Does anyone else in my group have something that they would add to that?
I definitely agree with Nick and kind of his stance on everything. I think that when looking into this, one of the main things that at least my opinions are, and that kind of align with my opinions, are just having a universal public healthcare system, but also allowing privatized healthcare as well for those who wanted that option. But I think making sure that we have reformed universal healthcare is one of the most important things that we could kind of offer to the public.
Thanks, Sophie.
Great job. Yeah, really excellent job with that, and really interesting topic. So thank you. We're going to jump to our next group, which is group 15, Alexis, Lauren, Hannah, Amanda, and Joe. And so I will turn it over to you.
Awesome. I'm going to try to figure out how to, can you guys see my screen?
We can, yep, it looks, there it goes.
Oh, did I fix it? Okay, awesome. Yep. Hi, everybody. My name is Alexis Prestel. Please bear with me. This is my 4th day of COVID, and I actually got dressed today. So it's a good day. I'm very thankful to be healthy enough to present. So today we'll be discussing the impact of unequal resources and accessibility to healthcare for veterans. In our introduction portion of we discuss the impact of unequal resources and accessibility, and we define how access can be defined as an individual's ability to obtain the healthcare they need within an appropriate amount of time. This has been a systemic issue in the Department of Veteran Affairs. We wanted to focus on how this directly affects our community in West Michigan, and we have a very large veteran population here, and we know that many people are affected by the accessibility and resource issues corresponding to the VA. If you look in our accessibility portion of the poster, you'll see the drastic wait times that patients experience while trying to receive proper care. Our statistics are specific to West Michigan and emphasize that there are some specialties with no clinics relatively close, within 50 miles. This means that for many patients in need of care, they're not able to receive it. A quick fact that touches on the accessibility is that there are no VA medical centers in Grand Rapids, despite this being the most prevalent population of veterans in West Michigan. The statistics that the accessibility portion comes from the neighboring city of Wyoming. This also prevents patients from getting preventative care, which makes the population's problem worse. Preventative care is a way to manage health without using full-blown resources that are more costly, time-consuming, and invasive. Without this, this becomes a problem, and the veterans are going to just continue to get worse. It enables resource issues and facilities where patients can easily access, allows for revenue and resources to follow. But for facilities where accessibility is difficult, quality of care seems to decrease. Quality of care is also impacted when accessibility issues prevent proper and necessary referrals for patients. This prevents patients from getting better care because referrals are so limited. So what are the outcomes of these issues? The most prevalent problem is the rate of homelessness and suicide among ill veterans. For veterans who do not receive care or proper health care, many are not able to maintain jobs or proper functioning and end up without homes, whether it's mental illness or physical disabilities. There's a wide range of spectrums. Even when people do use the VA for care, the lack of quality and accessibility is tolling for patients. The most damning piece of evidence that we found was a study in 2016 that said male veterans who use the VA are 22% more likely to commit suicide than the veterans who don't use the services. This should be concerning. Proper healthcare is supposed to provide support, not hopelessness for the people it serves. Statistics show veterans do not receive proper emotional care, and for homeless veterans do not get all the medical services they are supposed to have available to them despite their increasing needs. It is a vicious cycle. Lack of accessibility to quality healthcare causes the health of veterans to decline. This decline in healthcare can lead to homelessness as well as serious medical issues, which further makes accessing healthcare more difficult. This will continue like this unless healthcare professionals and future healthcare professionals like us and government officials do something to change it. From our research, we know that we are able to conclude that this is a serious issue, and so many people in our community here in West Michigan are getting impacted by it. We wanted to use this opportunity during the Health Expo to create awareness to the inequalities surrounding veteran access to care. We appreciate you taking the time to listen and hope you learned something valuable from this presentation. If you guys have any questions, please let me know and you can shout them out now.
Excellent job, Lexi. Any questions for her group? Really interesting topic. Give a pause.
Lexi, I noticed you talk about the accessibility. Did you come because that's not only a problem, is they go to a specialty. Actually, the treatment or the medicines prescribed by the specialist has to be approved by the primary doctor from the VA, and they may deny it. It costs too much. Did you find any data about that lack of, I send you to a cardiologist, by example, and the cardiologist give you Plavix, but then I don't want to pay for your Plavix that you need to save your life from having a heart attack. So
yeah. We actually didn't look in specific details, but I know exactly what you're talking about because my fiance broke his back in the Army. So he goes through the VA all the time. And he was literally just talking about this where they won't, they give you like, not generic necessarily, but just different medication that is the least expensive, may not work the best, but it's simple and it's prescribed and what is available through the VA. It's very inconvenient and not consistent either. They have some VA facilities that will prescribe some things and then some that don't. It's just inconsistent. And but we didn't do any specific research on that, unfortunately, but I do know exactly what you're talking about. And that is a very real and present issue that is still occurring in the VA for sure.
yeah, I got probably complications even more besides waiting long time to get treatment. Then
Yeah,
you get the right treatment.
exactly.
Unfortunate. Very good presentation.
Thank you.
I don't have a question, but I did want to kind of put a little input in as a previous medical practice for an otolaryngology clinic specialty up in northern Michigan. She did hit the nail on the head, and as you know, with your boyfriend too, up in our area there was no VA clinic to treat patients, so we did audiograms and hearing tests, and then hearing aid fittings, and it takes a long time to get an authorization from the VA. It can take 35 to 45, sometimes longer days. It's not within our practice. It was never within our practice. It was always within the VA, and it's a very frustrating thing for the veterans. So I just kind of wanted to put that out there because you did have the days to treatment in there, and I can assure you that there's many people that are really trying to be advocates for the VA and for the veterans, but they make it almost impossible for us to do that. And then my audiologist would have hours upon hours of paperwork to do on top of that for free. So great presentation though. I think that some of the things that you brought up were wonderful to hear and to see kind of another perspective, because sometimes when you're standing behind it all and feeling like you're getting aimed at constantly and you're worrying about patient care, you sometimes feel like the VA doesn't understand that, or the veterans don't understand that. So thank you very much for that.
Yeah, and thank you for your input too. It's good to hear that it's actually a real life example and people can relate to it. It's not just statistics on a piece of paper, it's real life experiences. So thank you.
Thank you, Lexi. Certainly a population that's underserved in many ways. And I think one of the most striking statistics on there was the male veterans who use the VHA are 22% more likely to commit suicide than veterans who don't use the services. I'll never forget, there was an article in the Washington Post a couple years ago, you can still look this up, that there were veterans actually committing suicide in the parking lot of VA centers because they weren't getting the help that they needed. And it was kind of a statement in some ways to say like, hey, I've been reaching out for help and haven't gotten it. So certainly a population, I think, is many of you going into healthcare, whatever that might look like, I think to be aware of and maybe look for some ways to improve based on the conversation. So excellent job.
Thank you.
Well, let's jump to our next group, which is Team 16, Farah, Haley, Monica, and Hannah. And I will turn it over to you. It looks like your presentation was on impact of education on quality and access to healthcare. So we will turn it over to you.
Wonderful. Can I share my screen? Oh, yes. There we go. All right. Hi, everybody. Welcome. My name is Farah. I'm going to be presenting on behalf of my group regarding the impact of education on quality and access to healthcare. just make sure I'm not muted. Our people's question states, will encouragement in pursuing education beyond a high school degree for minorities as compared to lower level education provide better health outcomes and increase access to quality healthcare? So from our research, we found that there's a strong connection between education and healthcare. In general, minorities not only face healthcare disparities, but they also face education disparities as well. For example, discrimination and racism reduces educational opportunities, which produces worse health outcomes. We found that less educated individuals often live in low-income neighborhoods that lack resources for good health and also lack economic resources for success. On the other end, higher educated individuals tend to have better knowledge of healthy behaviors, which allow them to analyze their health status and communicate that better to their healthcare professionals. In addition, higher educated individuals often have larger social networks, which allows them access to lots of resources that can help reduce things such as stress and hardship, which improve their mental health. Like I stated before, our population is minorities. We found that race, ethnicity, sex, gender, disability, socioeconomic status, geographic location all contribute to one's ability to achieve good health. Like I said before, education is a fundamental element of health, and it determines one's access to income, financial security, stable employment, safe neighborhoods, and healthier lifestyles, all which promote better health. We also found that higher educated adults report better overall health, less chronic conditions, and lower prevalence of disability, thus reiterating our point that education does have an effect on one's health. Looking at the figures, the top one looks at students who compared to students who mostly received A's, high school students who mostly received B's and F's were 11 times more likely to engage in illicit drug use, 4 times more likely to have 4 or more sexual partners, 5 times more likely to miss school, and twice as likely to feel sad or hopeless, thus demonstrating that less educationally successful students have lower health status and engage in risky behavior that affects their health. The bottom figure explains or demonstrates educational attainment between African Americans, the red bars, and the national average, the gray bars. Looking to the left, achieving a high school diploma or more, the gap between African Americans and the national average of those achieving a high school diploma has closed or narrowed in more recent years compared to over 70 years ago, where the gap was much larger. However, if we look to the right, where when achieving a bachelor's degree or more, the national average is much higher than the averages of African Americans achieving a bachelor's degree, which is why we thought it was important to research education disparities and its effect on healthcare, because this is still prevalent today. Thus, led us to find solutions for education disparities in order to improve health. One intervention aimed at educating and impact on individuals. In Georgia, the government implemented a Bright from the Start program, which integrated early childcare, nutrition services, and parent education. This addressed education and health early in the child's life before they even entered school, and also supported and educated their guardian as well on the importance of health and education. In addition, we found that partnerships between schools and colleges were successful in increasing minority enrollment in higher education. Another important intervention is educating healthcare professionals, especially education on cultural competency and addressing implicit biases, which can help eliminate ethnic and racial disparities in healthcare. We also found that therapists with a background in racial identity were better able to describe their patients' interpersonal issues, had better connections, and more intimate conversations with their patients. One last intervention was community outreach and government involvement. Here in the community in Grand Rapids, Spectrum Health provides community resources such as connections for financial, food, spiritual, and health needs. Thus, guiding minorities to these resources is a great way to increase their access to education and healthcare as well. This concludes my presentation. So thank you all for listening, and let me know if you have any questions.
Good job, Farah. Any questions for their group? Really interesting topic, and one that the field of interprofessional education is and collaborative care is addressing too, in the sense of finding ways to provide more patient-centered care and having diverse disciplines be able to contribute to the care of individuals. So this is certainly one that's very timely right now. So excellent presentation.
Thank you. And yeah, like you said, the interprofessional education models, I think they were like a great way to introduce this type of education for healthcare, for early healthcare professionals.
Great job. Thank you.
Thank you.
So let's jump to our next group, which is Team 17. Abigail, Alyssa, Caitlin, Cody, and Isaac. And their topic is looking at education access and quality, better education for all. So kind of a nice piggyback off the one that we just had. And I will turn it over to you guys.
Yeah, we have a pretty similar topic here, but we, here, I'm gonna try to share my screen. Oh, did it share? No. Oh my, I have to allow access.
Oh, is it? Are you having? Let me.
Yeah, I've never shared on Zoom before, so I'm trying to.
I can. You know what I'll do is I'll just go ahead and share it. I've got it pulled up right here, so I'll go ahead and share it for you, and then I'll let you talk about it.
Sounds good.
You able to see it okay?
Yep, I see it. All right, so yeah, so like I said, ours is pretty similar to the last group, but we focus more on the access side of it. And so the effects of access to life expectancy. And so looking at life expectancy, we kind of looked at things about stress levels and what it means to live like a healthier life and what college can do in terms of that. So, because we were kind of thinking like, our parents, like growing up, always told us, if you had, if you went to college, if you got a better job, you would have a healthier life, you would be happier. So we kind of just did research and saw and to see if that actually was true. So our PICO question was, how does access to high school and college affect an individual's life expectancy? So background here, right off the bat, we found that there is a clear correlation between higher education and a better life expectancy, and having those better jobs really does help. And if students aren't satisfied with their school and they don't move on, they do have those lower wage jobs, and then through research, you wouldn't really think that the lower wage jobs are harder to get, but it is kind of that way because there are so many people competing for those lower wage jobs and lower education jobs that it does negatively affect you. And then good health is associated with academic success. So now moving into who has less access to these. So time and time again, we were seeing that it is those with lower socioeconomic status. And now pulling in a reference from Smedley, Stith, and Colburn that we had, they stated that education is not only a ticket to economic success, but also a basic survival. So they're basically saying that it doesn't just help you with your economic status and money, but also just your basic survival and how you will prevail as a human. And like I said, they found that individuals with that are in the communities that are low socioeconomic status do have less access to education. And these programs, like compared to the predominantly white schools, like in, for example, my school, we had AP classes and courses that you could take kind of to prepare you for college or to know what you expected. Or even my school just like talked about college, and these low socioeconomic status communities, their schools might not even discuss the idea of college or visit schools or those kind of things. Okay, so now moving into the effects that this decreased access has. So like the list here, the individuals with less access to education experience 50% more worse health outcomes and life expectancies in the future, which is a huge change. It's crazy to think that just going to college or taking part in a good program really does help your life expectancy and help you live a healthier, better, longer life. And then not only moving on to college, but just the simple fact of finishing high school. And if you are in a high school or in a program that that you aren't happy with, you have a higher chance of dropping out and then having to compete for those lower level job or lower paying jobs. And we found that this increases your risk of engaging into crime. And now talking about stress, we kind of wanted to talk about mental health and stress and how that affects that, because I feel like in our life today with, of course, COVID, but also just in our generation, we talk a lot about mental health and what that is and how we can change that. And so we found that there is a huge correlation between the level of education you get and the amount of stress you have from work and then if you have lower education and a higher level of stress from that work, you also things like money and providing for your family and all these other aspects just kind of tie in and make it really hard for you to live a healthy life. And so then this stress then leads to that cardiovascular disease and an early onset death, which impedes on your life expectancy. Now to just kind of wrap things up over here in conclusions, we found that the key way of fixing this is just to spread information. We need to just let people know that not only are these kids not getting access to it, but they don't even have the opportunity to get access to it. A personal example, and my mom, she works for Lansing school districts and she's a teacher there. And so she works in an inner city school. And just in the last 5 years, they've implemented this program that it starts in 8th grade and goes all the way through high school. And if you maintain a certain GPA and you don't get in a lot of trouble and you continue with school at a nice pace, they will pay for your college and they allow you to go to a certain list of schools. And this kind of just encourages the students who come from a family that might never have gone to college or didn't even finish high school, to kind of give them hope and to give them that opportunity that they wouldn't have had otherwise. So I thought that was a great idea to kind of throw in, and it seems like more and more schools are doing this, but it's great to see that the schools in Michigan, like in Lansing, are actually implementing these programs. And then, just like I've been preaching this entire time, higher educated individuals do live longer, healthier lives. And this is kind of what our project encompassed fully. So yeah, and that's the end of my presentation.
Great job, Cody. Any questions for Cody or their group at all? I was looking up, you probably saw that there was this program that this reminded me of, that GVSU is offering this tuition-free program for qualified students from these 6 communities of families that make less than $50,000. And this was, I think, just announced, just this past February. So I think there's initiatives that I think are addressing these, or leaders that are trying to address these. I think the Kalamazoo Promise had a similar type of initiative to folks that went to Kalamazoo schools. I think had opportunity for free tuition at Western. And then I think someone might know more about this, but I think there was a recent announcement for access to community college in Michigan statewide, right? And I can't remember the details of that one, but certainly one, I think that both the topics that your groups touched on are, the nice thing about those topics, I think that they're initiatives that if, given the right attention and time and energy, can really improve health and access and care. And so really excellent and timely topic. And I think one that you can see some direct results through some of these initiatives and programs.
Yeah, it's great to see that these programs are starting up and things are actually happening with that.
Yep. Well, great job. Why don't we jump to our next one, which is team group 18. And this was Josh, Jean, Abby, Meg. And the title is Access to Specialty Care in Rural Areas in the United States. So interested to hear what your group found.
Is it Dr. Ulrich or Ulrich?
Ulrich. Yep, I know that one can be pronounced either way.
Ulrich,
But,
yeah.
yeah, thanks.
Is it possible for you to share it for me?
Absolutely. Yep, I can pull that up right now.
Thank you.
Let me just do the same thing I just did there.
All right. Thank you.
Yep.
So, good evening, classmates of Issues in Healthcare, Dr. Ulrich and Professor Sutliff. I'm Gene Ward. I'm presenting from my group. Thanks to Megan, Abby, and Josh for all the hard work. I have a personal connection to this poster in that I'm a parent of a child who requires specialty healthcare, and that she needs to see regular or have regular visits to an endocrinologist. And to do that, we often had to travel upwards of 4 hours when we lived in Oregon, and as little as an hour when we lived in North Carolina. So when we were brainstorming what we were going to do our poster on, I remember thinking when we would on these drives headed to our appointments that our particular situation allowed for us to just make the appointment, take off work, and just attend the appointment and not have to worry about the travel expense or how we might get there, taking off work, and the things that would go along with that. And one of the things I remember thinking was, what would it be like for someone who had lesser means or lived further out? So when we were brainstorming, I brought this up and we decided it would be a good topic to look into and see how it might affect those in rural areas. And it turns out that it can be a significant burden. If you see that number right there in the middle, 15% of all Americans live in rural areas. And that might not sound like a big number when you say 15%, but when you consider the population of America, that's quite a lot of people who live in rural areas. And you can read through and you see, it looks like it's probably pretty hard to see, but a rural area is considered 2,500 residents, and not developed. But we found that a good number of people who live in rural areas do suffer from not having access to specialty healthcare. And so we want you to consider this. If you get anything from this poster, if you go on to healthcare and you're on a committee that has the ability to change or affect the bring in healthcare to those in rural areas, possibly through doing travel for those specialty providers, doing local clinics and traveling to these rural areas, then please consider that. If any of my team mates have anything to add, please chime in. But this is my presentation.
Anything from the group mates at all that you wanted to add?
Yeah, so this is Josh. Kind of piggybacking off what Jean said, rural residents often have to travel a lot further to get healthcare versus, people who live in urban areas. And I believe, let's see, if you go down to the significance of, I was kind of looking off that there. Yeah, so more likely to travel those longer distances to access these specialty services. Let's see here. And then a lot of the times that specialists aren't in rural areas is because there's a lot less demand in rural areas than there is in urban. So that's why there's less access to those specialty healthcares because of just the lower demand in rural areas.
I like that idea that you have under the possible solutions, and I think this happens in certain areas, but this last bullet point you have of bringing urban specialists into rural health systems on certain days of the week. Certainly something that would improve access in terms of not having to travel as far.
Exactly. Yep.
Any other questions for that group? There's certainly I've often heard that rural populations are actually one of the most underserved populations in terms of healthcare and numbers across the whole country. Because if you think about geographic landmass of the US and how many people live in rural areas, I think Jean's illustration at the beginning of this talk, I think highlights a challenge and a struggle. I mean, I think many of us that might be sitting in or close to West Michigan may not have as much of appreciation for that, but it can be really, really challenging.
Again, if I can kind of chime in a little bit, as a previous owner of a specialty clinic who did serve Petoskey, Gaylord, we had clinics in Petoskey and Gaylord, Charlevoix, Onaway, and up in the Sault Ste. Marie and St. Ignace as well. I encourage those of you up in the rural area, and I'm only speaking because our clinic was closed with COVID. We didn't have the patients. We tried to do the outreach clinics as well, and it just wasn't happening. We all understand why, but it's life. But I do encourage that if they're in your area, use them. It's extremely, extremely expensive to have a satellite clinic. It would cost us in excess of anywhere from $8,000 to $10,000 a day to run my satellite clinic. And to run one single satellite clinic a month, it was like $75,000. So I encourage you to utilize them up there in the rural areas. It's really, really hard to keep them open, especially with the underserved and the underinsured. So please utilize them as much as humanly possible, and understand that there's many, many, many physicians that are really trying to reach out to the underserved areas and trying to reach out to patients. And we do know that it's hard. We would have patients traveling even in our Petoskey, our home-based clinic, up to 2 hours away, and just to get there and get services. And so use them as much as you can. Don't be afraid. We have many, many, many good providers up in that area that are just as good, if not even better, in my opinion, than some of your big based hospitals downstate. So please utilize them and, keep them up. That's how you're going to keep them in those areas, is by utilizing their services.
Thanks, Christy. It's good to be aware of that too, and how that cost is a major inhibitor at times, it sounds like, or can be if they're being underutilized. So thank you.
Yeah, that's a good point. Thanks for bringing that up. We did go one time, like we go to Grand Rapids right now. We did go once in Traverse City because they would come up and do a local clinic. But I didn't think about we always decided to go down there because we had that means, right? I didn't think about using them more to make them come up here more, because it never seemed like they came up here enough for us.
Yeah, and you guys hit the nail on the head when you said, it's hard to get them here. And you did talk about getting the urban doctors in. us little doctors up in northern Michigan, we want to stay there, you know. So bringing in, when the hospital brings in the urban doctors, or what we like to call the rent-a-docs, they spend thousands and thousands of dollars a day to have them in, and then they treat the local doctors like they don't mean anything, which puts a hard time. So if you can, I mean, obviously if people have to go downstate or they have to go someplace else, by all means, you have that right and privilege to do it. But if you can stay within your local towns and your local communities and utilize your local doctors, please do. A good physician or a good provider is going to tell you when they need to refer you elsewhere and when they can't serve you up in our area. But we have many, many, many doctors up in our area that are just phenomenal and really want to be there. So let's keep them there. I'm currently speaking from Houston, Texas, because we had to move there. So that's why I'm saying, please bring us back.
Thank you. Let's jump to our next group, which is Team 20 of Annie, Alexis, Allie, Courtney, and Haley. And actually, I'm sorry about that. I missed a group. So before you start, I missed it. It was Team 19, which is Joseph, Jesse, Keaton, Nicholas, and Catherine. Glad I caught that. And they're looking at lack of affordable healthcare impact in residents in Flint, Michigan, so more of an urban population. So I will turn it over to your group.
Hey guys, I'm Joey. I will be presenting for my group today. I just gotta share my screen real quick. Hopefully this works. Can you guys see everything okay?
Yep, looks good.
Alrighty. So
right
we did our,
the right side's a little bit cut off, but
is it? Let me see if there we go. Does that work a little better?
Yep.
Okay, perfect. So we did healthcare access and how it affects or how the cost affects residents of Flint, Michigan. We chose this because we are all from around that area, some of us within 10 minutes, and we played schools there, had to go to schools there for like sporting events, whatever it may be. So this one kind of hits home a little bit closer just because of everything going on there, especially with Flint water crisis and everything else. It's also deemed one of the most dangerous cities in the world, or state or country, unfortunately. But yeah, so this is why we kind of focus on that, because it affects people we know and stuff like that. So our purpose is to demonstrate how the lack of affordable healthcare impacts Flint residents as a whole. So the lack of affordable healthcare in the United States overall is a very big problem. And with rising healthcare costs and access to basic healthcare, it's not found very easily in a lot of areas. Even with health insurance, people often they struggle to afford being able to pay for health insurance. So that is a big damper on people because they do not, they'll go without for the most part, which is unfortunate because it leads to problems down the road. So we started off, we looked at the problems in the United States, which over 27.5 million people in the US lack healthcare coverage totally. And 45% of them state that cost is the issue to that. And we are a nation of 300 million people, so 27.5 million people. Being uninsured doesn't seem like that big of a number, but I mean, when it comes down to it, that is what drives our life expectancy down, premature death rates, stuff like that. So it has a giant effect on the country as a whole. So the average American household, they spend about $11,000. We found about $11,000 worth of out of pocket healthcare expenses, whether it be for pharmaceutical needs, routine visits and checkups and examinations, hospital stays, visits, and all that good stuff. And 50% of the United States adults have stated that because of these high levels of cost, they will go without because they cannot afford it, or it's paying a medical bill or putting food on the table for their family. And that's what it's come down to, our healthcare system in the United States. And out of those 50%, 1 in 8 people end up developing further complications due to not having preventative care in place beforehand. So like we said in figure 1, these are like the top 10 countries for life expectancy, and we are down here at number 8 at 78. And we are also one of the highest paying countries in the world per capita for healthcare expenses, which is a really big problem because that means we are not using our resources effectively, because we have all of the technology and things to advance our people in healthcare, but it doesn't seem to be occurring. So then we looked into a smaller localized group of people, which was Flint, Michigan. It's a very poverty-stricken city in Michigan, like you can see in figure 2 here. It's double the rate for poverty throughout the state, throughout the nation, and even throughout Genesee County, which is where it resides in. That's where we're all from, actually, in our group. But yeah, so the average Flint household brings in about $26,000 per year, and they spend minimum 20% of their household income on healthcare costs. And that is a very low number because coming down here, 6.3% of Genesee County are uninsured, and yet we rank 82nd out of 83 counties in the state for healthcare outcomes, which is very unfortunate. Just because we have such a low number of uninsured, but yet our outcomes are not very good. So meaning preventative care and other things are not being carried out as efficiently. So going back to this, in here in figure 3, we the pyramid, it kind of describes the lowest or highest and lowest impacts of healthcare. And the biggest impact is socioeconomic factors. And so basically just poverty, education, things like that were already presented in other presentations, all play that factor into what plays the biggest role in healthcare. And we've seen that cost and not having the accessibility because of cost is the number one reason why we have such bad outcomes in the United States, unfortunately. So our results that we found, healthcare coverage is not the main conflict, but rather the cost is crippling because of the prices. 17% of Genesee County residents report being unable to afford their prescriptions and copays for other types of whatever they have medically. And it's unfortunate because going back to that, 6.3% are uninsured, which is a very low number when you think about it. And Flint is actually, they have more people that are insured, higher than the national and state average, but yet they don't have the ability to pay for these things, so they lack preventative care, unfortunately. So there's not really much focus being placed on basic health and safety for these residents of Flint. So some solutions we looked into for the big major hospitals in Flint. You have Hurley, McLaren, Flint, and Genesis are like the big 3, and then they have an associate branch, which is the Genesee County Health Department, and they kind of run clinics throughout the county. So they have a few of these programs in order to combat the lack of affordable healthcare in this area. We have the Children's Oral Health Task Force, Adult and Adolescent Partial Hospital Program, Genesee County Free Medical Clinics, the Patient Care Fund, Child Evaluation Clinic, and many more. So these all cover bases from oral care to vision to mental health, whatever it may be. All these hospitals have, they donate time and money. A lot of physicians, they give about 2,000 hours a year is the average for a resident doctor to give back to these clinics. So they kind of cover all the bases on that. That way people can start having some preventative care, because that is going to overall boost health outcomes, because preventative care is the number one prevention method. Yeah, so with all the help of that, that's kind of what's going on right now. Unfortunately, with the health, or like the water crisis and everything else, that kind of put things down in the dumps even more, because people were dealing with problems they never had before with the lead poisoning and mental health deficits and stuff like that that had been produced from that crisis that is still ongoing. But yeah, we're slowly getting back into the swing of things in Genesee County. So yeah, that's kind of my presentation.
Great job, Joey. And I found one of the, under that, the problem in Flint, one of the more fascinating, I think, bullet points is that, you know, just around 6% are uninsured, yet the county is almost dead last out of all the counties for healthcare outcomes for the past 3 years. So it kind of speaks to a broader problem that you kind of touched on, just, you know, in terms of access and programs that I think can help just get people in. I mean, that's a huge hurdle, is to just kind of make people aware of the programs and you know, get them in. I think one of the bullets under the problem talked about 50% of adults skip necessary medical service. So that's a huge one, is kind of getting some of that preventative care. Any questions for Joey's group?
Real quickly, in your research, I love the fact that you focused on a specific area or region. Did you find any research indicating that there was a delay in access to care with the recent water problems that we had in Flint, pollution of the water?
We didn't necessarily research that, but we did see there was a cost increase within the area because of healthcare and stuff like that. Yeah, that's pretty much it. I mean, we're coming on, I think, year 4 of being, it's not a state of emergency anymore per se, but the lack of clean water still a thing. So they're still working out the kinks and whatnot between that. So they're slowly coming back to what they used to be, but not completely.
Excellent, thank you. I would imagine that access to care during a local regional emergency such as that would be highlighted. It highlight the access challenges.
For sure, yeah, it definitely was.
Well, great job. I think that was a nice kind of piggyback off talking about rural access. I think that there were some nice tie-ins related to more urban underserved areas of medicine. So great job. Thank you.
Yeah, thank you. Oh, and just to point out one more thing, just because we were talking about like the 82nd out of 83rd, I believe the 83rd, the last ranking county was Wayne County, Detroit. And so that's another urban area that doesn't receive adequate health care because of poverty and socioeconomic status. So that was just another thing that we found.
Yeah.
So.
Great. Yeah, thank you, Joey.
Thank you. I'm just gonna stop sharing.
Let's jump to our next group, which is Team 20. Consists of Annie, Alexis, Allie, Courtney, and Haley. And they are talking about the effect of education on life expectancy. So I will turn it over to your group.
Hi, I'm Annie, and I'll be discussing our topic for our group. Would you be able to share our presentation for me?
Sure, absolutely.
Thank you.
Let me just get it open here. I'll zoom in here too. It looks like it's a little zoomed out.
Okay, cool. Thank you.
Yep.
So our topic is the effect of education on life expectancy. And throughout our research, we found that education attainment has become a profound predictor in length of life, and actually it's been surpassing gender and race. Highly educated Americans typically are living longer than low educated. And a way high education is becoming a predictor is it's a big factor when it comes to high income jobs, and high income jobs that in turn access to things like housing, food, medical care that can ultimately affect length of life. So by finding out about these things, this led us to our question about how does education access and quality for higher and lower education affect health determinants and life expectancy in the US. So just some key things that we found. A master's degree brings about 14.7 more years in life expectancy compared to those who did not finish high school. And it also brought 8.3 more years than people who did finish high school. So those who do have higher education, like a master's degree, are having longer life expectancies, compared to those who did and did not finish high school. Another big thing that we did find was race and access to education are being intertwined. We found that the race gap narrows at higher levels of education, and we also found a substantial larger education gradient for African Americans compared to Caucasian populations. And if you look to the figure to the left, this is just demonstrating the prevalence of dementia for African American and Caucasian populations, and then it also separates education status. So even African American populations that did complete high school, at a time they were having a higher prevalence of dementia compared to populations, Caucasian populations that did not finish high school. So this disparities in socioeconomic status in relation to life expectancy has been widening the past few years. So this is a big significance when it comes to researching this topic, because researching effects on education on life expectancy can lead to developments and other paths and explanations to human mortality. And another thing that we found through our study is education policies can also be seen as indirect health policies. So when our society is making policies about education, it's really important to keep in mind that the policies that we are making is having a huge impact indirectly on our health. Just to sum things up, so there was a clear gradient by level of education showing that high education has the highest life expectancy, and the study from 1990 to 2010 showed education disparities in life expectancy grew among all race and genders. So without accessibility to quality education, lifespan can definitely be altered. If there's any questions.
Great job. Any questions for Annie or her group?
How did you guys feel about the research you did, just thinking about that master's degree and just the disparity there of how many people can actually obtain a master's degree when we think about, the national population? It is pretty low overall. And so how did you guys feel about that disparity and just those outcomes that you found?
I think I was definitely, I don't want to say surprised, but it definitely brings like my focus, like more attention about the disparities that do stand in like our society. Like there's so much pressure about having education and going to college. I definitely think there should be like more research and developments when it comes to education access, just because it is showing to be super important, especially in life expectancy. But yeah, I think just the disparities, like seeing that, kind of sad, honestly, just not really, a lot of populations not really having a lot of access to education, and that is like impacting how long they live ultimately, and it's pretty sad.
I agree with you. And I think it's a good thing to bring out and to talk about, because I don't know about you guys, but for me, when I was in your shoes in college, even when I was in my master's degree and now in school again, we focus on the pressure that we feel to get through, right? It's so hard to get through and get that GPA and get into that graduate school. And it's just part of what we're doing that we forget the level of privilege that exists just in that alone, and when we think about the patients that we're going to come and see, there will often be a stark difference between our own opportunities and then the perceptions that we have based on that as we then project towards our patients. So it's really important to keep those IPE concepts in our minds as we think about cultural competency and communication and training and educating our future, or your future patients, I should say. I think is really important. So I appreciate your poster. I thought you guys did an excellent job. I really liked the layout too.
Thank you.
I agree. Yeah, nice job, Annie. I've thought about, because there's been a few on this topic this evening, how this past year with school closures and hybrid and virtual and shifting back and forth will impact, education broadly. I think there will be retrospective studies probably looking at how this, impacts things like the value of education or how individuals value education. Is this year going to set some students back more than others, especially in K-12 settings, and early education in particular? So I was kind of thinking about that a little bit, and that's going to be interesting just to see how that play. Are students going to be able to get caught up? And what are going to be some of the long-term ramifications for how school was impacted?
Yeah.
A great job. Why don't we jump to our next group, which is Team 21, Carly, Leanne, Anne-Marie, Ketria, and Christy. And they had a presentation on access to care in the maternal health of African-American women. So I will turn it over to your group.
Yeah, this is Christy, and I'm going to present. I'm going to try to share my screen here. Let's see here. Are you able to see that?
Yep.
Okay, let me see if I can make it a little bit. Is that better?
It is. Yep, looks great.
Okay, great. So good evening. I'm Christy Slater. On behalf of my fellow group members, Anne-Marie, Kate, Carly, and Leanne, I am here to present our poster on healthcare access and quality. I think we can all agree that access to quality healthcare is a problem in our country. My group and I know this and wanted to dig just a little bit deeper to what we believe is just one small chunk of our country's problem, which is the significant discrepancy that African-American women have in maternal health outcomes. With that said, we wanted to do some research to confirm our thoughts. Our quest in this research was to find answers to our PICO question of how does healthcare access impact maternal health outcomes for African-American women? Through our research, we have gained a better understanding. There were a couple of facts that introduced us to our PICO question. One, access to healthcare services in the United States is often dependent on one's proximity to healthcare services, health insurance, and socioeconomic status. With that being said, Black women in particular are 3 to 4 times more likely to die from pregnancy and childbirth-related complications than white women are. And 2, the United States has the worst statistics out of any other industrialized country when it comes to maternal mortality rate. Before I go on, let me define what maternal mortality is. Maternal mortality is defined as the death of a pregnant woman during pregnancy, at delivery, or soon after delivery. The US also statistically has a higher maternal morbidity rates, which are unexpected outcomes of labor and delivery that result in the significant short or long-term consequences. So we're talking about losing lives, and my group and I believe that this is pretty serious. We did many literature reviews, however, there were a few in particular that stood out to us. One cohort study found that African-American women had increased risk for infection, hemorrhage, hypertension, and preterm labor compared to their white counterparts. The Center for Disease Control and Prevention says pregnancy-related mortality ratios for African-American women in the United States are higher than that for white women, regardless of education level. A population-based study found that factors such as individuals' residence, insurance, proximity to hospital, and racial segregation can in fact influence the maternal health care. A 17-year period study involving hospital discharge records from California concluded that the racial prejudice and stress experienced by African-American women is in fact associated with decreased birth weights and corresponding severe maternal morbidity. And finally, a systematic review suggested that African American women that were uninsured or using Medicaid delivering in rural area hospitals were at heightened risk of developing severe maternal morbidity. Now, our question is still, so how does access impact maternal health outcomes of African American women? And you're probably, maybe some of you are wondering why we would, in a rural area in northern Michigan, would be researching specifically African American women, but we again believe that it's just a small chunk of that. And we wanted to kind of pull that out. I can assure you that in northern Michigan, we do have the problem. As well as we have the problem where I'm at here in Houston, Texas. It's unbelievable here. So to answer the question of how does healthcare access impact maternal health outcomes for African American women, Black mothers are more likely than white mothers to deliver at high-risk hospitals and suffer severe maternal morbidity. There is implicit racial bias that has been reported in the healthcare system, which can affect patient-provider interactions, treatment decisions, patient adherence to recommendations, and patient health outcomes. With that said, on behalf of my group, we concluded that there are many barriers African American women must face when receiving maternal care, and because of this, they experience a higher risk of complications compared to white women. No new mom should ever have to worry about receiving quality, compassionate healthcare and how they can access this. This shows that there is and are still indeed many issues within the healthcare field that must be reevaluated and addressed. Our country needs to find a way to provide quality healthcare and access to African American women. With this project, I have had a unique opportunity to group with 4 other fantastic ladies who are all going into the healthcare field. We all hope that we will find ways to look at our own implicit biases, use our own discoveries to advocate for African American women. We vow to gain a better interprofessional education where we will learn about, from, and with each other to improve healthcare outcomes. And lastly, we pray that starting with the 5 of us, and hopefully you will all join in, we will somehow make a small impact on the entire healthcare system that will indeed bridge the gap, allowing more healthcare access and better healthcare outcomes for African American women. We thank you for your time and consideration in this matter. Any questions?
Great job, Christy. Any questions for her or that group? Any group mates that wanted to comment at all? Interesting topic. I appreciated that you kind of focused on a particular population.
Students, don't be afraid to ask questions of each other. You don't have to worry about, is this a good question or not?
I just want to, if I can add a little bit, I know I've touched base a little bit on the fact that I've moved and I'm now in the greater Houston area. I want, and being a non-traditional student, I think it's important to mention that we are very sheltered in northern Michigan from a lot of diversity, and we're learning it and we all want to learn it, but until you get thrown into it, you don't really realize how sheltered we are. And it is up in the northern, Michigan area and even mid-Michigan as well, where we see, discrepancy in healthcare for African American women. But here, I've been doing a little looking around in this area, and it's really bad. And so, since I think we're all going into healthcare, most of us, anyways, I encourage everyone to, as we're going through these presentations, please look within your own self and see how we can better bridge these gaps.
I agree, and I mentioned that to the students yesterday too, that I think a lot of this information is important to, not only doing the research for your own topic, but kind of taking in what other people are presenting. As you mentioned, many people are going into helping professions broadly, healthcare probably more specifically, and just having kind of an awareness. I mean, we've talked about a lot of different populations, from veterans to African American women, and how education, can impact health outcomes in more urban areas like Flint. I think all of this is really good information to have going forward, to just be kind of aware of what the research and data suggests. So Yeah, great job. Thank you, Christy.
Thank you. Thank you for this opportunity for us to do this.
Let's jump next to group 22, which was Madison Shelby, Doris Haley, and Jonathan. And they've got a presentation on the influence of provider burnout on quality of care during the COVID-19 pandemic.
Yes, hi everyone. Okay, let me just share my screen. So when we were deciding topics, COVID has obviously been so prevalent in the past year, and we wanted to look at how the COVID-19 pandemic has affected provider burnout and how that burnout has affected the quality of care within the past year. So can everyone see my screen good? Okay, sounds good. So our PICO question is, what are the effects of provider burnout during the COVID-19 pandemic on quality of care? So just a little bit of a background on burnout. Burnout is exhaustion resulting from stress and demand in the workplace. And specifically to healthcare, that can be emotional exhaustion, it can be physical, it can be detachment, so not being as personable with your patients, and it can also be seen as reduced personal accomplishment or a reduction in goal setting. Physician burnout has always been an issue in the healthcare field, but my group has seen, and as we did our research, we saw that the COVID-19 pandemic has just exacerbated that issue, mainly through physical and emotional stress. So our providers were working a lot longer hours than they ever had before. They also weren't taking breaks, and they had a lot more patients in just a short amount of time. So that was a lot of the physical stress that they had to deal with on a day-to-day basis in the past year. And then also just the emotional stress and the stress and fear of catching COVID and bringing COVID home to their loved ones also factored into the emotional stress. So with the higher workload, and they had stricter guidelines and just a lack of support, all of these providers were dealing with the same issues. And so it was hard for them to support each other during this time, and which left them not much time to cope with the challenges COVID brought. Like I said, they had an increased patient load. And so it was hard to find time, to cope with those challenges that this pandemic had brought. So to back up a little bit of the information that I'm discussing, we found a few studies, and one of the studies that we found told us that 60% of healthcare workers during the COVID-19 pandemic were working 40 to 50 hours a week, and then 75% of them are reporting burnout. And we saw that this has been a lot higher than in the previous years before COVID, and that directly just relates to how an increase in work hours can create a burnout. And then we also found that burnout rates were higher with providers in their ages in the late 20s to early 30s, and it was actually lowest in those 40 and older. So we did find 3 main effects of burnout that we thought were very interesting. So the first one was depersonalization. So the providers during the pandemic, they had to care for patients at a rate that they had never had to care for before. They had to care for patients very quickly, just because there was so many patients to care for. So it was hard to be personable with each patient. And then we also found a strong relationship between burnout and medical errors. Because providers were working at such a fast rate, there was an increase in medical errors. And then since there was an increase in medical errors, that created its stress of its own and distress. So it was kind of a vicious cycle, and which ended up creating more medical errors. And then the third thing that we found was that there wasn't successful discharge management. As we all know, there wasn't enough room or enough beds in hospitals. And so discharge management wasn't always done correctly. Maybe people or patients who weren't supposed to be discharged had to be discharged to make room for those patients who, were doing even worse. So the discharge management just was not as successful during the pandemic as previously done. So we did find a few strategies to decrease the burnout. One of them was just redesigning the workflow. And I think that has a lot to do with interprofessional teams that we've been discussing a lot this semester. Just everyone taking the same amount of work, and just so, not the whole workload is put onto one person, I think is really important. So just redistributing the work so that everyone has an equal amount of work and no one has to feel that one stress for that workload. We also found that the electronic health record system, and this entails technology, and obviously we know that technology has increased the way that we communicate nowadays, and especially in the healthcare field. It just sped up the documentation process for providers so they could spend a little bit more time with their patients. And then I think the most important one, and I think my group would agree with this too, was that the implementation of support systems is very important within the healthcare field at this time. It was hard to, I think, support providers during this past year just because we didn't know how to cope with the challenges that COVID-19 brought. But it is very important to have those support systems so that providers can discuss their feelings and the challenges that they have had to experience during this time. So a summary of our slides today, we have seen that COVID-19 has exacerbated provider burnout, which has led to a decrease in the quality of care just through depersonalization, medical errors, and a decrease in successful discharge management. We also have seen that some strategies to help provider burnout has been workload redistribution, your electronic health records, your EHRs, and social support, and then just an increased attention to emotional well-being for providers, I think is very important. So looking back at that PICO question, what are the effects of provider burnout during the COVID-19 pandemic on quality of care? The top three that we found for that question is depersonalization, that relationship between burnout and medical errors, and that decrease in successful discharge management. And that is the end of my presentation. Does anyone have any questions?
Great job, Madison. And obviously this is an extremely timely topic. And one that's, I think, impacted healthcare workers across the world. I think, like your presentation highlighted, there were particular, obviously, nuances to this because it was so new and novel that kind of exacerbated and already burned out in many ways. I think, especially for physician burnout, there's some really staggering statistics related to healthcare workers and burnout. And so some of these, I think, strategies will be, an ongoing aid well beyond COVID-19 pandemic. So absolutely, I think this was really interesting, and thank you for highlighting a real important topic.
Yes, thank you.
Any other questions for Madison's group?
So for your project, you guys looked at providers. So just more specifically, are you talking about like doctors, or are you just talking about healthcare professionals in general?
So we just discussed providers in ours, but I think a lot of this has to do with healthcare professionals too in general. You can relate it to, especially the strategies. I think not just providers can impact from this, but all healthcare professionals, especially the support system. I think all healthcare professionals can benefit from that.
Yeah, great job. Thanks, Madison.
Thank you.
We'll jump to our next group, which is group 23 or team 23, which was Lindsay, Gabriel, Madison, Madeline, and Riley. And they are looking at healthcare for minorities in the emergency department, so culturally competent caregivers. And I will turn it over to you.
I'm Madison. I'll be discussing our topic. Can you put our poster up if possible?
Sure. Yep.
Thank you.
No problem. Let me just do a screen share here. And I'll zoom this in.
Perfect. Thank you. So our group decided to talk about healthcare for minorities in the emergency department specifically. Most of the group, myself included, worked in some type of healthcare institution. That being said, we decided that looking at the care provided in specifically the emergency department differs from Caucasian people to people of color. Doctors, nurses, etc. face challenges every day in the emergency department, whether that be a difficult patient, a difficult diagnosis, an ongoing treatment that is not working, and anything in between. One thing that can be challenging to all employees is that they are faced with language barriers. The emergency department often compensates for failures of the rest of the organization because they are the first line that interacts with patients. As we have learned in our AHS class, cultural competency is an important aspect of the quality of care and can make or break a patient's satisfaction. These language barriers are something that we can overcome with the implementation of cultural competency training. Our lack of cultural competence has many impacts in healthcare in general, but especially in the emergency department. Primarily, the people who are impacted most by this lack of cultural competence are mostly those in poverty, as well as ethnic and racial minorities. Not only are these groups underserved in healthcare, but they are also underrepresented in the emergency department. According to one of our sources titled Cultural Competence in the Emergency Department, of the 1,268 faculty members in the AAMC database, 82% are white, while only 10.8% are from underrepresented minorities. Lack of cultural competence also affects advances to reduce or eliminate disease, as these reductions are not equally distributed over all ethnicities and races. In addition, an example of a lack of cultural competence is shown in the amount of Caucasian patients who receive pain medication when in the emergency department when compared to both Hispanic patients as well as African American patients. The studies by Wolf and Calms show that Hispanic patients were less likely to receive pain medication in the emergency department after a long bone fracture when compared to non-Hispanic white patients in a similar situation. In a similar study, Black patients were 66% less likely to receive pain medications in the emergency department when compared to white patients. There are a few ways to improve these issues of cultural competence in healthcare organizations. One way to improve cultural competence within an organization is to have a defined set of values and principles within the organization. It is important to demonstrate culturally competent behaviors, attitudes, policies, and structures to create a culture of accountability for these actions. Doing this will create a safe environment for patients, as they will be treated with the same respect and understanding by everyone they come into contact with. It is also important to value diversity and differences. One way to do this is through self-assessment and the acquisition of cultural knowledge. This will allow workers to adapt to diversity and best serve the communities in which they work. It is important that cultural competence is taken into account in all aspects of policymaking, administration, and practice, as this is the key to providing the best care for patients. In order to address the previously mentioned impacts, a few tools can be used to reduce the lack of cultural competence in emergency departments. The Cultural Competence Health Practitioner Assessment, also known as the CCHPA 129, has 129 items and is a psychometric evaluation of cultural competence for nurses and doctors. This assessment allows healthcare professionals to self-assess their capacity to deliver care to culturally diverse individuals and underserved communities and promote cultural competence as an essential approach for practitioners working to decrease healthcare disparities among racial and ethnic groups. The 129 items on the assessment cover multiple, sorry. The 129 items on the assessment cover multiple domains, including values and belief systems, cultural aspects of epidemiology, clinical decision-making, life cycle events, cross-cultural communications, and the health management, as well as a demographic section. The CCPHA 129, along with the implementation of cultural competency training, could lead to equal treatment and less health disparities in emergency departments. In conclusion, emergency departments can decrease the lack of cultural competent care between minorities and Caucasian-Americans by using cultural competence training to further educate healthcare providers and create quality care for all patients. Solutions to improve lack of culturally competent care include the use of the recently published Cultural Competence Health Practitioner Assessment and providing training on cultural competency to employers in order to increase the awareness and improve one's own cultural competence. These resources have been shown to provide useful professional feedback for practitioners in organizations seeking to increase practitioners' cultural competence. In the long run, this will potentially improve minority patient experience in the ED and health outcomes. And that is all. If anyone has any questions.
Good job, Madison. Really great job. Any questions for Madison or their presentation related to healthcare for minorities in the emergency department?
Yeah, I have a question. So why do you think that Black people and Hispanics are given less analgesics than white people?
Sorry, can you say that one more time? It was like cutting off on my computer.
Okay, why do you think minorities receive less analgesics than like white people?
Okay.
I can talk on that if you want me to, Madison.
Go ahead.
Yeah, so in the study, it said that a lot of the providers actually think that there's a difference in physiology between African Americans and Caucasian Americans or Hispanic people, but you typically see it more with African Americans. So a lot of that is actually just like wrong assumptions that they have. So that's why we think that this training can be so important to help reduce some of these disparities.
Okay.
It's really particularly important for the emergency department, which is, the true front lines of medicine. They're seeing a wide range of individuals every single day. Thank you. Very, very excellent presentation. Thank you.
Thank you, guys.
Let's jump to group 24, which Nathaniel, Brandy, and Sarah. And their presentation is about the impacts of underinsurance on American adults' access to healthcare. So we will turn it over to you.
Are you able to pull up our poster as well?
I can. Yep,
Thank
absolutely.
you.
How's that?
That looks good. All right, so hi everyone. My name is Nate and my group members are Brandy Wilson Odom and Sarah Zarebski. So our poster is based on the broader issue that many Americans are underinsured. Underinsurance is defined as out-of-pocket costs that equal 10% or more of the annual household income So in 2018, out of 194 adults between the ages of 19 and age 64, about 45% of those individuals were underinsured. So some of the causes of this underinsurance could be related to the cost of premiums in general, the cost of premiums rising at a different rate than the increase in wages, lack of coverage within a plan, high cost of deductibles or co-payments, as well as the lack of approval for these individuals for a plan. So as a response to the issue of underinsurance, the Affordable Care Act was passed in 2010. So with the Affordable Care Act came insurance coverage for people who had pre-existing medical conditions, which was extremely helpful for a lot of people. A lot of Americans are now able to access healthcare through their employers as well. And although the Affordable Care Act did help with a lot of the underinsurance issue, the problem with the cost of healthcare in general was still not addressed. So in the 10-year span between 2008 and 2018, healthcare premiums increased at an average of 4% annually. And as a consequence of underinsurance, Americans are unable to properly pay when medical issues arise. So about 34% of uninsured individuals were unable to cover their medical expenses compared to 14% of those who were insured, and they were able to cover their medical expenses. 19% of underinsured persons reported being contacted by a collections agency in reference to their unpaid medical bills. Another 18% stated that they had to alter their lifestyle in order to cover their medical bills. 7% of underinsured Americans reported that they had to file for bankruptcy due to medical debt. And on the contrary, in adequately insured Americans, only 4% filed for bankruptcy. So you can kind of see that it's a huge issue that the underinsured Americans can't really make ends meet, and it leads to other issues in their life as well, other than just paying the bills. So the inability to cover medical bills isn't the only problem. Patients are also choosing to not fill prescriptions so that they can avoid medical costs. They're also reporting skipping medical tests, treatments, or follow-up visits due to the cost involved with these. So this poses a significant issue that is not really being addressed. Although the Affordable Care Act did help to bring healthcare to many people, there is still a large part of the population that is not able to afford adequate healthcare. So as a result of this, patients are not really receiving the medical care and attention that they need. A lot of Americans cannot even afford a medical bill of $1,000, and having any unanticipated medical expenses could significantly affect other aspects of their lives, kind of like what I was talking about with the bankruptcy and other issues. So that being said, the United States does have some of the highest quality healthcare, but unfortunately, a lot of circumstances like what I said about rising premiums, deductibles, and not matching the rise in wages, this can create a barrier between Americans and adequate healthcare coverage. So based on the statistics that we presented on our poster, you can kind of see that the majority of the underinsurance has to do with basic inability to afford health insurance from the beginning, as well as the fear of the cost of the services involved, medications, or treatments that may be involved as well. So that kind of wraps up our poster, unless anyone has any questions. Thank you.
Great job, Nate. Any questions for Nate or the group? Really interesting. I appreciated all the statistics that you guys included, and it's a real interesting, almost kind of snowball effect that, underinsured when they need access to healthcare, are paying for it at a high rate, but often need healthcare to live a healthy life. So it's just a real interesting kind of research topic, and I think some other groups have touched on this peripherally as well. So great job.
Thank you.
Yeah.
Yeah, I was gonna say I like the information. It
I agree.
It reminds me of our poster. That was definitely one of the things that were a barrier to the access to specialty healthcare.
Yeah, and 87 million. I mean, it's a really high number. It's a really high number of Americans that are underinsured. So again, an important topic to kind of stick in your back pocket for all of the students going into healthcare on that call. So thank you. Let's jump to our next group, which is team 25. And their presentation looks at the relationship between geographic location and specialized healthcare access. Interesting. So I will turn it over to your group.
Can you hear me?
Yep.
Awesome. Brian, can you do me a favor and please put that
Sure.
on your screen as well? I have
No problem.
issues with my computer.
Yep, no problem. Glad I had these all on the website. This would have been a more daunting task if I had to pull them up from email or something. All right, let me just zoom in here. Can you see that okay?
Perfect. Works out great. All righty. Hi, everybody. My name is Trevor Dunn. I'm presenting along a poster alongside of the names of Alexandra Liebestil, Brittany Berardi, Mykola Prinzinsko. I'm so sorry if I botched that last name. And then Phelan Welch. We also go by the Fantastic Five. And we are talking about the differences between specialized medicine and care between geographical location, specifically focusing on urban as well as rural. The concept of this topic came from much of the pandemic, as well as previously conversations of other healthcare disparities, things of like cancer and other cardiovascular diseases. But the premise goes as such: being that most generally specialized and subspecialized care is more considered to be in a more metropolitan area, i.e. a Grand Rapids, a Detroit, just to name a few more local familiar cities. Those areas in the urban environment have a higher, more focused and more reachable subspecialty, or at least access to care, whereas the population in those areas have the ability and the means to reach it. For those people who live in populations who live in more rural communities, that access to subspecialized care is not always granted. That can result in higher mortality rates, more contributing to future illnesses that could relate to such things that could be already omitted with diet, such as obesity, or just education and access to going to a more primary care provider, which will lower the rates of preventable diseases. So hopping into our poster right here. So as I mentioned, we're talking about the differences between rural and urban. So focusing just on more of the visuals before I jumping right into it, focusing on these two articles and these two images right here. It's kind of hard to see. If you can zoom in a little bit, that's okay. But the first one on the left focuses on the differences between rural and urban in terms of cancer percentages. So if you can focus more kind of on the concept of what's going on here, that the darker shaded blue is really depicting on the areas of access to where cancer care is more prevalent. So seeing the shading and seeing what the differences are, you can kind of see already a representation of there's already a divide. And then we transition to our second topic of the sign right next to in figure 2, that's breaking up the access to medical care beds as well as physician ratio. Now the ratio, as I mentioned previously in my opening, is being in a metro area, more urban, having more access to these subspecialized care, you're gonna have more high-level providers able to fit the bill and meet a higher patient ratio. If you're in a rural environment, based off economic needs, as well as the community's ability to supply a provider, as well as supply resources, you may be having very few physicians, or you may have a more advanced medical provider as a physician assistant or a nurse practitioner to fill that need, which relates into our overcoming the barriers. So as I just mentioned, due to these costs and times of the distance that is put in place by rural and urban medicine, that can relate and contribute to future and further illnesses. If you're 100 miles away from the nearest cardiovascular clinic at the Meyer Heart Center downtown, if you don't have the necessary resources or means to be able to travel to said place, or even the education to even access said place because of your rural environment, you're not necessarily going to be receiving the best care. Now, if you live in a more urban environment where that type of infrastructure and that educational model of what those types of facilities provide, that's more common to you, and you at least have more access and the ability or option to essentially attribute and use those resources. As well as rural areas having more concentrated outreach to get more concentrated outreach and a more difficulty to receive resources and supplies because of them being away from more of the higher market areas, such as the more metro, like I said, Grand Rapids or Detroit. It's going to be a similar to a trickle down effect of how much resources are going to be available. And we refer to the pandemic that we're currently in at the beginning of this, when PPE was an issue for many of a majority of the PPE that was prevalent went initially to hospitals, went to the higher hospitals that had the higher capacity to see more patients, which relatively makes sense. However, when you're considering that to other communities, such as rural communities, they're going to see basically what's left. And for those communities, they're going to be receiving less resources, less care, and less ability to do like a equitable job considerably to what the resources are provided. So the barriers to this care, so we'll go with barriers to this care. So the three things that we found, there are four, but three that I believe are very valid to put out. It seems a little odd to read off this one. So health insurance coverage, the percentages are actually lower of uninsured patients in rural areas and higher in urban areas. So it seems kind of odd and juxtaposed to kind of consider that. However, when you focus on patient population and ratio per capita, it kind of makes sense. If you have a higher density of people living in one area, and they're not necessarily either in the means to have the ability to access insurance, whether that be through work, financial capability, not understanding the economics or the offered resources that insurance provides to them based off their identities or whatever their social class and status is. So there's that type of issue that can relate to people even having the ability to even access care, because as previous groups have just mentioned, not a lot of people have the ability to pay off $1,000 ER bill. So if you have something that you can consider treatable, you're going to try to do it yourself and can do more of this backyard medicine and senses like that. And as previously mentioned, transportation distance, as I recently recalled, if you're 100 miles away from the nearest specialized hospital, you're going to try as hard as you can to get there. But if you're 100 miles away and you realistically don't have either the financials or even the transportation methods to get there, you're not likely going to be able to access those places and use those resources, especially when you consider elder populations. A lot of elder populations who are stuck in these rural areas don't have the ability or even means to even meet with said providers that can focus on things like oncology, cardio, pulmonary, neuro, and all of those follow-ups and check-ins with those types of providers in specialized care can actually prolong their life, but since they don't have the ability to reach them, higher mortality could ensue, if not already. Poor health literacy. If we're focusing on just urbanization alone, more urban, higher academies, a majority of higher education institutions, such as colleges and universities, are more densely located in urban environments, or at least have access to urban environments, i.e. Grand Rapids, Grand Valley State, kind of commingling with that relationship. Students or people growing up in the population that don't have access to said care and their educational exposure to the medical field is very low, or don't even have the ability to understand what the due process is for going in to see a physician or see a provider. Having those restrictions and barriers to receive that type of care can already exacerbate and increase the ability of mortality as well as the quality of life. And I said three, but of course we always have to mention socioeconomic status is a big factor. If you live predominantly, and this is more of a predominant or of a kind of, I would say, I'm trying to think of the word, assumed. If you're more of an urban environment with a higher GOP in that area, and you more than likely have a higher education, have degrees, things of that nature that are standalone like facts that can help you move up the ladder and become more of a socioeconomic benefits to that, you're going to either have insurance implied inside your job, access to healthcare, or at least the knowledgeable through work-life relationships to have knowledge how to access this care. More common in urban environments because of the greater exposure. Now, they're not to say that people living in these higher metropolitan areas cannot be on the lower economic statuses. There's always been seen that, i.e. we can look at Detroit and again, Grand Rapids, using those two just because they're local cities that we're very familiar with. There are unfortunately populations that do enter that line of low economic status. But being said with that, again, they don't either have the knowledge, the outreach of resources, or at least the ability or comfort level already for that factor to access these types of cares. And then when we compare that to rural, it goes to just the same. Not knowing anything about medical or how the due process to be when you are sick or when you think you need to go see your primary care provider can very detrimentally restrict you from actually seeing that provider if you don't understand the severity of why it is important to go see them. If we go up to the impacts of patient care, focusing on things, oncology, I mentioned it already. If you're 5 miles or within an urban environment or even a suburban environment, relatively distantly speaking, you're having to go to treatments because of, we understand that chemotherapy is very detrimental on the body and takes a big toll. Definitely decreases your chances of going through and completing treatment the further and further you come out, because it becomes a bigger task to get back to treatment. We focus on OB with women. Women in rural communities also have a more likely chance to have experienced birth defects, which is a percentage of 67%. Again, that being not having the ability to resources to have the proper equipment or proper professional staff around them to even have to go through labor and do those offsetting things after labor is completed to make sure that baby and mom are both safe and healthy. So things like that nature can also be an issue.
About 1 minute, Trevor.
Okay, cool. So wrapping this all up, why is this all important? So after we looked at the data and talked about what we've seen on both sides of the point, rural residents have a poorer health than urban counterparts, significantly for 3 reasons: resource limitations, overlapping roles and providers, as well as serviceable access to providers. Those 3 reasons alone are contributed to the facts that not only we're seeing the pandemic, but the epidemic with opioids, as well as obesity. And that is our project. Thank you.
Really great job, and some very telling statistics that I think you included. Appreciated the graphs that you highlighted early on too. So any questions for Trevor or their group? I think a very interesting topic that we've kind of touched on a little bit in some different ways, but I appreciated how you kind of brought that all together on a national scale. See if there's any questions. I'll give about 10 seconds to see if anyone has any questions for their group. Yeah, great job. Thank you, Trevor.
Thank you.
Excellent job. Let's jump to our next group, which is Team 26, Sydney, Amanda, and Emma. And their topic was looking at, does the level of education correlate with access to quality healthcare in the United States?
Hi, everyone. My name is Sydney, and I'm going to be presenting the poster for my group. Myself, Amanda Beatty, Amanda Spicer, Emma Kane, and Clark Frick put together this poster talking about the correlation between levels of education and access to quality healthcare in the United States. Our PICO question specifically was, does the level of education correlate with access to quality healthcare in the United States? We found this graphic kind of putting together the components of factors that affect access to healthcare. So anything from education, neighborhood, transportation, socioeconomic, and then economic stability. The background of our topic has a couple different components relating to education, insurance, and location. A lot of people in the United States with lower levels of education do not have equal access to healthcare because of their location, and things like transportation, locations of doctor's offices, emergency departments, and then also lower levels of education can translate to a lower understanding of medical problems. So people with less education might not realize that they're ill or injured. They might not know the extent or severity of their injury or illness. And also they may not know what type of doctor to see if they don't have a primary care doctor or an urgent care nearby. And finally, people with lower levels of education might not have a job that provides insurance for them to utilize all of the healthcare. The methodology of this presentation was an interprofessional team of 5 undergraduate students that were looking to answer this question above through peer-reviewed articles. We met up and researched and then put this together. So the results of this study was we did find that a lack of education is related to lower access to quality healthcare. These differences between access to healthcare can be explained through things like ethnicity, race, and immigration status. Those with less education are more likely to have more illnesses and higher medical costs. One thing about that is that we found they are more likely to have illnesses and higher medical costs because they're not able to treat it right when an illness onsets. They may not realize they're sick, or like I mentioned, they may not know who to go see for that. And that can lead to more severity of that illness or other medical problems that could have been avoided if they had access to healthcare right when they needed it. And then race and ethnicity disparities caused premature deaths relating to education. And then also immigration status and education can be a predictor of what people would rate their own health. And then, so in conclusion, we came up with public health platforms could be a good fix for this. Public health such as PSAs, education in school before college, and just groups that have the ability to reach more people and give them information about nearby urgent cares, nearby emergency rooms, and just public health platforms that can decrease the gap between education and access to healthcare, because everyone should have access to healthcare around them, regardless of their education status. And even more so, as we said, people with lower education are more likely to have health issues and premature death. So they need it even more than those that are highly educated. And then also, kind of like I already said, education of healthy living habits. So again, all of this relates to public health in some way, just really reaching all of the communities, even lower educated communities, about healthy living habits that can hopefully prevent some of the chronic illnesses that have to do with things like unhealthy diets, lack of exercise, smoking, drug use, alcohol intake, things like that, just educating. And that primarily comes from public health platforms. And then I think that's all. Thank you.
Thanks, Sydney. Yeah, great job. Any questions for Sydney or the group? Great job. Yeah, thank you, Sydney.
Thank you.
Excellent. Jump to our next group, which is Team 27 of Kelsey, Taylor, Mackenzie, Bryn, and Janelle. And they are looking at the impact of socioeconomic status. How accessible is healthcare? So we will turn it over to your group.
Okay, are you able to see my screen?
Yep.
All right. Hi, everyone. My name is Taylor, and I'm presenting on behalf of my group, which is Kelsey, Bryn, Janelle, and Mackenzie. We are talking about the impact of socioeconomic status on healthcare access. So first and foremost, I just want to show our PICO question to everyone. We were just researching whether or not socioeconomic status affects healthcare access and quality. So before I jump into it, I'd like to just ask everyone to do a little bit of interacting with me, just thinking a little bit about what we're going to dive into. So I'm going to say a word or a phrase, and I'd like everyone, you can write it down or you can just think in your head the first things that pop into your head once I say the word. So I'm going to start with uninsured. So if everyone could just think for a second what you think of right away when you hear the word uninsured. I know for me, I think of really high healthcare prices, maybe a job that doesn't have insurance, maybe unemployment, or a really low income job. I think of frightened when entering the hospital, or maybe not enough knowledge about the healthcare field or medical issues just due to that insurance. I honestly think of like rotting teeth and not visiting the dentist enough. We're gonna do it again, but this time I'm gonna give you a new word. So this new phrase is high socioeconomic status. So if everyone could just write or think about the first things that pop into their head when they think of high socioeconomic status. I know when I sit and think of that, I think of a nice car, a good education, a well-paying job, maybe a big house in a nice neighborhood, you know, the top percent of the wealthy. So there's definitely quite a switch when we think of that word. I'm gonna do one more where now everyone is gonna think about the first things that pop into their head when they think of low socioeconomic status. So for me, actually, I thought of uninsured when I did this first with the group. We did it kind of to prepare for our presentation, and I thought of kind of the same qualities that came into my head when we thought about uninsured. That's probably because there's a really large relation between uninsured and those who fall into the low socioeconomic status or class. Now, just thinking about what we thought of right away in our perceptions of these groups of people, I'm going to ask you to think about how many of us are in the medical field. So that's probably all of us. We are going to have something to do with the medical field or health as we, dive into our careers. And the reason why I bring that up beginning this presentation is because not only are people who fall into low socioeconomic status or class more likely to be uninsured and have poor quality of health, or that to be known as a risk factor for them in their health outcomes, but clinical perceptions are actually proven to play a role in this and the quality of care that people with low socioeconomic status receive. Just it affects clinical decisions and healthcare delivery. So I'm going to use myself as an example for a second. I have worked as a physical therapist tech for a year or so. I now work at Butterworth as a nursing technician. I don't necessarily make clinical decisions, but I definitely deliver care to a lot of people. And then thinking about my future, I'm, going to continue to work as a nursing technician until I attend PA school next fall, which I will do. And then at my program, I will attend clinical rotations where I will start making those decisions and then deliver more care to even more people. And then I'll graduate from that program and I'll work as a PA for the unforeseen future. So if we just think about how all of those patients would be affected if I were really conscious about drawing a baseline of not thinking about low or high socioeconomic status amongst my patients, but instead just focusing on giving everyone the same amount of care, just myself, that would involve a lot of patients and probably provide a different care outcome for many of them. And then if we think about everyone who's on this Zoom, and if everyone was really conscious about not noticing the gaps between the socioeconomic status between their patients and how many lives that could change, or how much care delivery that could change for people to not feel like maybe
they don't deserve the care. So that's just something we thought would be interesting for everyone to think about and be conscious of as we continue. So moving on to our significance, I really believe that if you are in the medical field, this topic should be significant for you. I'm assuming that everyone has entered into the healthcare field because they want to help, and probably not because they only want to help people who are in a high socioeconomic class. So if you just think about that, if we can really focus on helping everyone, and even though it's not just our decision whether or not people have access, that just affects so many people in the medical field, but so many people in the general public, because so many people fall into this low socioeconomic status, and because of that are not receiving the same amount of access to healthcare and the same quality or delivery of healthcare. So in order to find our results, we utilized a few designs of different studies that we found that directly related to our topic. So we laid out the designs and implementations of these studies in our design and implementation box. And a few of the studies, we had patients recruited specifically who were on Medicaid. We actually found that approximately 90% of them were below the 100% poverty line, which actually helped our study, because then we could see how each patient explained their healthcare experience in general and in more specific to clinics, and how they felt their access was given to them. So how often they felt that they felt comfortable going to a hospital, or if they could afford it, or what they could afford and what their insurance covered. And then we did look at a specific study in regard to African Americans who were in the age gap of 21 to 63, who had more chronic illnesses, one or more chronic illnesses. And then they too answered some questions about their access, whether or not they were receiving beneficial treatment, and how that treatment actually did benefit or did not benefit their states of their issues. So in our results section, we actually have just a lot of pieces of information that really display how much of a risk these people with a low socioeconomic status are for having worse health, not being as comfortable going and seeking help, dying in hospital, dying because of certain diseases, not being able to access healthcare compared to individuals with higher income and education, as well as comparing education and how that affected the healthcare access that individuals were given. They overall just tend to have lower health outcomes and experience more difficulties in accessing health. So as I move to our summary, I really want to highlight that we observed just an alarming unequal access to the use of healthcare or healthcare services due to lower socioeconomic status. But that's not just in America. We actually saw it in most countries. We had a hard time finding studies that were actually only gone through in America. And just to tie that to something a little more personal, I know someone added to this earlier, but I'm kind of gonna add a little personal example to how sheltered we can be in West Michigan, but also just around Grand Valley and Michigan in general, maybe in America in general. I studied abroad in South America for a semester, and I lived with a host family for several months. And when I was there, I quickly realized that there was no heading to the doctor for a sore throat or an earache or an infection of any sort, or sometimes even a limb that might be broken. I noticed that my family utilized a lot of natural people who had no degree, who were not in the medical field whatsoever, but who would come to our house and kind of rub oils on us or say some prayers or sing some songs. And I would ask my host mom about that, and she would kind of laugh when I thought I should go to the doctor about like an ear infection that I had had for a few months. And after I returned home, my host father actually had a stroke. And after that, my family reached out to me a lot for simple things that I would never have guessed they needed. I was shipping them TheraBands that I could get at my physical therapy clinic for, free from them. Or my mom's a PT, she could just get me some TheraBands or little things that would help with him regaining his strength in his left side, was where he lost all his feeling and all of his utilization. But I was shipping things that I would never thought that they couldn't access. And I asked my host mom about that, and she just explained to me that they didn't have any insurance that could cover those things. And physical therapy was coming straight out of pocket. That was nothing that would have been covered, even though he had a stroke. And, you know, it was out of the blue. And I think that is something that we really do take for granted. And this obviously happens in America too. There are people in low socioeconomic status that can't afford a TheraBand and can't afford to go to physical therapy and are gonna pay a fortune just, you know, to get their loved ones through surgery and little things like that, which I think, especially going into healthcare, just being very honest and not sheltered towards the gap that we see between low socioeconomic status and high socioeconomic status, and just all that we can do together to help provide better access, which is something that overall we felt that we could provide better access if the healthcare coverage was expanded, but also the things that we can control, which is our health delivery and our health care that we are going to provide to our patients. I definitely don't see this issue all of a sudden getting better overnight. There's a lot of research that shows just how big it is and how it's actually been growing. So I'm really thankful we got to talk about this topic. And hopefully we can see, you know, in our lifetimes and our experience as healthcare workers, actually to see a bridge in the gap a little bit. Yeah. And then here we have our references.
Thanks, Taylor. And I appreciated how you talked about not just from a systems level, but as individuals, how there can be impacts made on a daily basis. And that's sometimes overlooked. And I think not always thought about how important sometimes those relationships that providers have with patients or whatever role you might play, how important some of those daily interactions can be. Sometimes you might not know what those outcomes are, but those relationships and ability to understand an increasingly diverse and pluralistic patient population as you all go forward, I think is going to be so crucial and important. So thank you. Very good presentation.
Thanks.
Yeah, thanks, Taylor. Any questions quickly before we transition to our next group for Taylor or Taylor's group?
I have a question / comment for you guys. Hi, Taylor. Thank you.
Hi.
You know, you mentioned the idea of just, you know, not looking at socioeconomic status as a barrier because of the perceptions. And I really agree with you and had made mention to that a little bit earlier. You guys went so great in detail to it. But as I was listening to you, the tension between what you're saying and making sure that we're not treating people differently and that we're providing the same amount of care came up for me. There's a tension between that and then recognizing what someone's socioeconomic status is, what their insurance is, what their ability to carry on a treatment plan is, you know, all of those practical things that are related to someone's treatment plan and what we do and offer as providers. I think it's there's a tension there between ignoring that but yet not ignoring it, because we can't put our patients in stressful situations that they can't meet the demands of what we're trying to prescribe. So I wondered if you had any thoughts about that.
Right. I actually completely agree with you. It is hard because at the same time, socioeconomic status plays such a big role because, you know, essentially someone comes in with a healthcare insurance or not a healthcare insurance. And that unfortunately lists kind of everything that is available to them. You know, a lot of times it's the treatments they're receiving. So I know that that is just such a huge step. And in order to get all the treatments that are necessary, sometimes they're going to have to look beyond their healthcare coverage. And I think just as providers, we can say that, or we can just act with a lot of empathy and understanding. I think the goal isn't to actually ignore it, but to be really honest with our patients about it. Hey, we know that you don't have a health care coverage to cover this. We know that, you know, things are going to look a little different. And I think actually just working with them on how we can overcome or go around what's not insured and what is insured with them is probably the biggest way that we can help. Just being brutally honest that we do know where they're coming from and we know exactly how much they're going to get from their insurance and how much they're not. And just developing a plan to, you know, get them everything they can without going broke. You know what I mean?
That's a great answer.
Taylor. Thanks again. Great job. the presentation and very interesting research. Thank you. Our next group is team 28, which is Gregory, Garrett, Olivia, Cade, Vanessa, and Carly. And they looked at education access and quality, particularly the effects of low income on pediatric healthcare outcomes. So excited to hear what your group has to present related to pediatric healthcare outcomes.
Hi, could you actually project our poster as well?
Yeah, got it up right here. There you go.
Hi, I'm Olivia. I'll be representing our group as we talk to you guys about the effects of growing up in a lower income family and how that exactly kind of impacts children and their health and their outcomes. So we set out to research if a child that is born into a low income family experiences decreased healthcare outcomes compared to those that aren't. And it actually is true. Like they do experience less because of the family that they were born into. And this isn't something that only impacts them as a child. It carries on into their adult lives. We're not saying that this occurs with, every child that grows up in a lower income family, but it's to the point where it's witnessed enough as like an apparent trend with that population. So it needs to be addressed. Statistically, children living in poverty are at greater risk for poor cognitive, behavioral, and health outcomes. And as I said, it not only affects them at the age that they're at right now, but it also affects them way long after they're children. This is something that's important to identify because as of 2016, approximately 20% of all US children live in poverty. So it's not something that's super uncommon, and it puts a lot of children at risk for having lower healthcare outcomes. Our group then decided from that point that we wanted to look into specific problems, what they are witnessing with these children, and kind of see what solutions that they have out there. One thing that was shown was that there is issues with language development, and they also have increased chances of chronic illness and injury. And the proposed solution to this would be to create stronger public policies, like expanding what's covered in the Children's Health Insurance Plan, which is also known as CHIPS, which is a low cost health coverage that is offered to parents that have high enough income that they don't qualify for Medicaid, but they still need that medical assistance. Or we could also increase the child tax credits. Or another thing that was brought up that was kind of interesting was that early childhood education programs, all of which could allow for more time and money and resources to be spent on kids. The next one that we kind of came across was the inverse relation between school absence and physical activity. So those that are more physically active are seen in school more. It's problematic because when kids aren't in school and they're not being physically active and not working on their physical health, and then they're missing out on learning and growing in their cognition, they're missing out on all those aspects. It's no secret that physical fitness is important not only for your physical health, but for your mental and emotional health. And if these kids are missing out on all of those aspects, it really puts them at danger for being successful in the future. Also, being in school is so important for kids because it not only provides them a safe space where they're guaranteed meals. We have so many meal assistance services for kids that are come from lower income families, but teachers are also trained to be aware of what they're witnessing with kids. They monitor their safety. They monitor if there's anything going on at home, if there's any resources that they can provide them through the school, like counseling or like therapy. So to fix this, we need to introduce interventions that are tailored to what kids need. So for like that instance, it would be tailoring to try and make kids more physically active. It's like, not everyone goes through physical education, especially in like middle school or high school. Like you can opt out of doing that stuff depending on, what the programs require. So it's important that the trends that we're witnessing, we're able to intervene in an appropriate manner. And then lastly, we looked at adverse childhood experiences and how they lead to toxic stress and how hard toxic stress is on the body. All of the questions on the ACEs test are relatable to stress. And one literally deliberately asks if you have enough to eat, or do you have to kind of fend for yourself at home? Do you have enough clothes, kind of type of question. So it's directly being related to basically, is there enough money for you, at home? And though it's been seen that those with high levels of toxic stress, like living in poverty, are having really long and bad effects on their health. To solve this, we need to be able to identify what children are struggling with and provide appropriate and timely interventions for what issues we're seeing with them. This comes from the ability to visit doctors. If you don't have the ability to visit a doctor, they're not going to be able to, catch things prematurely that could have been avoided. And being at school, like I said earlier, witnessing stuff that they, see outside of the home, or being able to provide, services that maybe aren't going to be able to be something that's paid for through the family if they can't afford it, but they're able to do it through the school system. So like, for example, if you're witnessing the speech language development issues, getting them into like speech therapy, seeing, a language pathologist, just intervening when you can, because that's something, like we said, that can be carried into adulthood. So we're trying to lesser these chances. And many of the issues that are being witnessed are kind of intertwined. So, if you catch one, it kind of cascades into, helping another. So it's really important that we are intervening so we don't have to see these negative outcomes between children that have different, socioeconomic levels. Because of this trend and the effects that it's having on children, they have put into place many different assistance programs like Feeding America and Supplemental Nutrition Assistance Program, which is known as SNAPS, to make sure that kids are getting enough to eat, or Big Brothers Big Sisters that encourages kids to stay in school. Also CHIPS, like I said earlier, all are targeted to help provide kids with resources that, help them stay in school and help them get the care that they need. Since income and healthcare are so intertwined, so we recognize that lower income students are more susceptible to these decreased healthcare outcomes. It's important that we prioritize in their health and support these assistance programs so that we can reduce the negative health outcomes that we are seeing in pediatric patients. Especially right now because of COVID-19, a lot of people are experiencing financial struggles, and they're also needing more support with their mental health. I work at Helen DeVos in the emergency department, and more times than not, I'm getting pulled out of the emergency department to go and be a safety attendant because we're seeing such a serious problem with kids and having mental health issues. So we need to just really be aware of how low income students are very susceptible to having negative health outcomes compared to those that are higher. Did anyone have any questions?
Great job, Olivia. A really, really interesting and important topic.
Mm-hmm.
I mentioned there's a program many of you probably are familiar with in West Michigan. I mentioned this at the program last night, Kids Food Basket, that's trying to tackle the, being able to offer nutrition support. And I think they have the capabilities to offer lunch and dinner to many families across West Michigan. And that was kind of started, as a grassroots, not-for-profit, and it still is nonprofit, but the amount of growth that it's had and just the recognition it's had in West Michigan, I think even in the past 3 to 4 years has been immense. So certainly important interventions in many ways. And I think this highlights many of those. Any other questions for Olivia or Olivia's group? Great job. I appreciated the content and you did a great job presenting.
Thank you.
Thanks. We'll jump to team 29, which is Holly, Sienna, Grace, Morgan, and Erica.
Hello.
And they have a presentation on healthcare barriers on lower socioeconomic Americans, the journey up.
Hi, Sarah. Can you hear me?
I can.
Okay. Do you mind sharing our poster for us?
Yep. And it's a little quiet, so I'm not sure if you're able to move a bit closer to the microphone, that might help a little bit.
All right. Is this a little better?
A little bit. Yep. Overall, I think, yep, we can hear you.
Okay, perfect.
Able to see that?
Yep, that's good. So I know we already talked about this a couple posters ago, but I'll be presenting for Holly, Sienna, Grace, Morgan, and myself. And this poster will be talking about the impact of healthcare barriers on lower socioeconomic Americans. So to begin with our PICO question, what healthcare access and quality barriers do Americans of lower socioeconomic status face? Access to healthcare means to have the timely use of personal health services to achieve the best health outcomes. The main barriers to accessing healthcare in America include high costs, insurance status, distance, and transportation. People who are more likely to have a low socioeconomic or social status are more likely to have difficulty accessing healthcare. As a result, high healthcare costs, being uninsured, and a lack of transportation often leads to poor health consequences. Next, I'll be talking about the first barrier to healthcare in America, which is cost. A main barrier to accessing healthcare is the high cost to quality care. If healthcare costs so much to get to individuals that fall in the lower class, they could struggle to get or qualify for healthcare due to not having enough money to cover insurance or transportation, having an impact on the overall experience. In 2003, 9.9% of low-income individuals incurred total burdens exceeding 20% of family income, an increase from 6.7% in 1996. This shows that the increase in healthcare goes up each year so that most individuals are spending their income on paying for care that is needed long-term or even short-term. Out-of-pocket payments for healthcare services by patients increased $162 billion in 1997 to $236 billion in 2004. This is even with some getting covered partially by insurance companies. The largest increase of the risk of experiencing a high total burden was occurring among individuals living below the federal poverty standard or the lower socioeconomic class. Something that was put into place was a large expansion through the state children's health insurance program that helped protect low-income families from bearing the financial burdens of rising healthcare costs when their children gain eligibility for public coverage. Although things like this that are included in insurance programs can be helpful for those struggling with money to pay for healthcare, insurance can still become a barrier. Next, we will talk about how insurance can impact the access of healthcare. Impacts healthcare access and quality is insurance coverage. In 2006, poor and near poor populations accounted for 2/3 of the uninsured population in the US. Most Americans obtain health insurance from their employer. However, low-income workers are less likely to acquire health insurance through their jobs than high-income workers. And even when they are offered coverage, it is often too expensive for them as their income is stretched across other expenses, such as food and housing. Low-income individuals also have an increased risk of being in poor health. 11% of uninsured individuals report significant health issues compared to 5% of individuals with private insurance. Preventative care is also impacted by lack of insurance. 32% of low-income women receive an annual mammogram compared to 64% of uninsured or insured women. Studies have shown that uninsured individuals who have chronic illnesses receive less care than insured individuals who have the same chronic illnesses. For example, uninsured patients with chronic heart conditions are significantly less likely than insured patients to receive essential cardiac procedures and are at a greater risk of dying from a heart attack. Lack of insurance and low income leads to poor health outcomes, which can also lead to delayed cancer diagnoses, high rate of avoidable hospitalizations, and premature death. In 2008, Medicaid provided coverage for over 55 million low-income Americans. This number greatly increased upon the implementation of the Affordable Care Act in 2014. The ACA improved coverage by expanding Medicaid income qualifications to 138% above the federal poverty line. The ACA has made great improvements in expanding health insurance coverage. However, 32 million Americans remain uninsured, most of which are eligible to receive benefits. This gap in coverage is due to the additional barriers, including lack of awareness of expanded eligibility, cost of coverage, language barriers, and difficulty navigating the enrollment process. As of 2016, 19 states had not expanded Medicaid coverage under the provisions of the ACA, leaving 3 million low-income Americans without insurance. The ACA has made great progress in expanding health insurance coverage and improving health outcomes. However, there are still challenges that we must overcome. The third and last barrier we will be going over is distance and transportation. In the United States, all over the country, urban and rural communities are struggling with reliable transportation. Within healthcare, the inability for Americans to efficiently get to their healthcare facilities is leading to poor illness management, missed doctor's appointments, and leading to overall poor health. A study was done that had shown individuals with no license and a lack of proper transportation had 4 more care visits on average per year than individuals that had a license and readily available, reliable transportation. So this is a class of Americans that are in need of proper transportation more than ever. Poor transportation infrastructure in this country, such as railway systems and subways only providing for particular regions, and poorly operated bus systems are affecting the ability for this class of people to get the care that they need. A high percentage of people using these unreliable transportation systems are chronically ill, disabled, or obese. The lack of proper access to care has Americans in these communities without a way home from emergency visits and missed doctor's appointments, ultimately leading to lower overall health, which they are struggling to manage getting to the facility in the first place. We believe that further research needs to be done with transportation behavior and its relation with healthcare in this country. We need to improve geographical access to healthcare facilities in these communities that are struggling to get the care that they need. Now that we have covered the barriers that socioeconomic groups face when it comes to healthcare, I'll be moving on to how these barriers impact patients.
Eric, about 1 minute, just letting you know.
Okay.
Thanks.
Delayed care in lower income patients lead to hospitalization and more health complications, along with more medical bills affecting those who are struggling with gaining access to insurance. Many patients who are treated poorly by trained physicians have trouble maintaining healthcare physicians compared to other communities. Current studies show there is 15.4% of patients who are uninsured that still have to pay a full cash payment when they are leaving their healthcare appointments. Access to healthcare varies across the country, including insurance becoming available to those of socioeconomic status. After hearing this presentation, I hope you all understand more about the barriers different socioeconomic groups face when it comes to healthcare. If you have any questions, I can try and answer them for you.
Great job. I appreciated how you had this laid out. I think the tell them 3 philosophy is a really common, like in written or oral presentations, kind of having like 3 main points for an audience. And I like how you laid that out with the 3 barriers of cost, insurance, and distance and transportation. So great job on this. And I think the bullet points under those were really pertinent and timely as well. So thank you. Any questions for Erica or Erica's group? Great job. Thank you. Thank you.
Question, a common observation that we have so many opportunities to kind of look at the marginalized communities with our healthcare, don't we? And so it's really nice to see the continuity with the research, but also from the different angles. It's as future practitioners, I mean, we have a lot of work for us, don't we?
I was thinking that similar thing in terms of, there's been different angles on geographic regions or specific patient populations. And it's been really just interesting to kind of see the smorgasbord that's been presented kind of related to this topic. And education has been a big one. But I agree. I think if anything, it's really bringing home the point of how important this issue is. But yeah, thanks, Noah. Great point. Let's jump to our next group, which is Team 30, Jenna, Grace, Chase, and Rachel. And their presentation was on exacerbation of heart disease due to inaccessibility of cardiovascular care in rural communities. So interesting topic. I'll turn it over to your group.
Hey, Brian, do you mind pulling it up on your screen again?
No problem.
Okay, so our group, composed of Rachel, Jenna, Grace, and myself, focused our research on the effects on those without access to cardiovascular care in rural communities. Individuals in these communities are less likely to receive care, which decreases their quality of life. This is caused by many issues, including scarcity of medical care resources, financial strain, and avoidance of care. We examined how this issue affects everyday quality of life, how the quality and timeliness of care affects the patient's recovery, and the reasons the patients receive less care than their urban counterparts. The high significance of this issue is demonstrated by the large percentage of Americans living in rural communities and affected by these issues. We see upwards of 15% of the US population lives in rural communities, and everyone in these communities is affected by these same rates. First, we covered the effect on everyday lives. Heart failure is a common cause for hospitalization and readmission. People in rural communities have less resources that they can devote to healthcare due to lower incomes. These lower incomes have limited access to healthcare. They cannot afford medications or copays and have higher prevalence of all health conditions. They also experience higher readmission rates for cardiovascular care in hospitals. We were even able to see a disproportionate amount of healthy options chosen by rural residents, causing more heart issues to begin with. Heart care providers prescribe cheaper medications to those who cannot afford better treatment, and many will go without treatment entirely, thus contributing to a shortened lifespan and an overall decreased quality of living. For those who are recovering, recovery for MIs and other cardiac injury patients is hindered by insufficiency and distance from healthcare facilities. Underprivileged communities within these rural areas struggle with transportation to the hospital during an emergent episode, and their fatality rates are much higher than those with better access to over-the-counter drugs, transportation, and shorter distances to the hospital. We looked at two big areas for causes for the disparity in care between urban and suburban or metropolitan regions. And the biggest two factors were the shortage of healthcare workers and healthcare avoidance. Well, at least ones that we could find in research and think of ways to help correct. Although there are many factors contributing to the decreased access to healthcare in rural areas, the largest that we can see with data is the shortage of healthcare workers and the avoidance of care. We have a shortage of medical facilities and undue financial strain on the ones that do exist in rural areas. This is in large part because of decreased funding and a shortage of healthcare workers in these areas. This causes increased travel and wait times, as well as decreased quality of care received when someone makes it in to receive their care. One of the largest causes for this phenomenon is the lack of healthcare education programs in rural areas. Almost 70% of residencies are located in the northeastern United States. 86% of those are non-primary care, and 99% of them are located in non-rural areas. These limitations prevent our physicians from ending up working in rural areas and reduces the amount of preventative care for all conditions, especially ones like heart disease, diabetes, and cancers. Rural communities are even further separated from care through their own avoidance of it. They are less likely to seek care than their urban counterparts, even if they can afford it. This issue causes those that could receive care to avoid it and reduce the amount and quality of care received. Barriers such as stigma, lack of privacy, lack of culturally appropriate interventions, and acceptance of poor health are all documented in these rural communities. These people can be helped with increased education in public schools and through advertisements for healthcare treatments that could increase the quality of or extend their lives. To increase accessibility to healthcare in rural areas, medical students and physicians should be incentivized to learn and practice in rural areas. Physicians and all healthcare workers can work to improve their care for rural communities by participating in a coordinated team that provides patient-centric care and helps new patients understand and navigate the healthcare system, especially if it's foreign to them. It is important to practice cultural proficiency, creating a welcoming and non-judgmental environment, and build trusting relationships with our patients. It is also helpful to establish realistic plans and priorities to achieve health goals and improvement. Healthcare providers should also advocate for their community, provide materials to support low-income families at little to no cost in order to promote better self-care, and increase the amount of patient education both in practices and in public schools can help prevent conditions from occurring and possibly even spark children's interest in healthcare, increasing the number looking to medicine for their careers. By increasing the quality of care, patient behavior and quality of life can be improved, all the while reducing negative health outcomes. That's all I got for this one.
Great job, thank you. Yeah, really interesting. Well, previously, prior to this, I worked in medical education, and a couple of points you made on here really reminded me that one of the biggest factors for where physicians practice is the residency, where they ended up doing their residency. And I saw you pointed out that too, that a lot of the slots are in non-rural areas. One interesting thing, I know at least in Michigan, there are some hospitals in rural areas, Marquette, for example, that are incentivizing physicians to return back to those areas by paying for some of their medical school debt. And so there are some efforts to help turn that tide a little bit, but it's still, due to a lot of things you noted here, challenging.
I'm looking into physician assistant studies myself, and there are programs that are willing to entirely pay for PA schooling for you to practice in an underserved community. But typically most of those ones are purely for affairs like the VA or other programs, and you have to work with them for, I believe, at least 2 years afterwards.
National Health Service Corps, I think, is another national program, kind of like a Peace Corps type thing, but for healthcare workers, where you can get education debt paid off and for, in turn, giving service to underserved areas. But yeah, excellent presentation, and I think highlights in this, in particular, cardiovascular care, but really great. Thank you. Thanks, Chase.
Thank you.
Any questions at all for Chase's group?
Just a comment. I worked with a group of cardiologists for a while, and they have their areas of specialty, but the electrophysiologists who do the heart ablations get paid the most compared to the doctors that are doing your heart stents or valve replacements. And this particular department that I was at, the electrophysiologist got recruited to Bourbonnais, Illinois versus Southwest Michigan, which Bourbonnais is a suburb basically now of Chicago these days. So, but my point is, again, that salary factor is a big factor, and that's a big specialty area in cardiology, and that makes the most money for the department too, those procedures. So like you said, money has a lot to do with it in terms of pay. And so one thing that's happening too is that a lot of the smaller hospitals are being absorbed by larger hospital systems to be able to retain the physicians, because these smaller, for instance, cardiology departments might not be able to put out the salaries, whereas they allow maybe a larger entity to buy them out. Then they might be able to at least start to offer some salaries that would look attractive for cardiologists. So yeah, the whole money game is very complicated.
Good point. Thank you.
Add on to that with having larger hospitals by the smaller ones. I work on a cardiac heart failure for Spectrum, and we get a lot of direct admits from outlying hospitals. So whether it's Big Rapids or Gerber, or even like we'll get people from Sparrows and Lansing and stuff like that. But basically, they'll go into the ED there, and then the doctors don't have the means of helping them for one reason or another, whether they have something that's more complicated or they need a special kind of surgery. So I think that they're doing better about getting into the rural areas and more outlying smaller hospitals. But as soon as you need something that's a little bit more complicated, that's when the travel comes in, and that's when those extra expenses, and it makes it more complicated for people to receive their quality care.
Thanks, Emily. Great point. We'll jump to our next group, which is Team 31, Ashley, Bridget, and Riley. And their group is explore the impact of early and adequate prenatal care. So an interesting topic we haven't heard much about this evening.
Hi, everybody. I think,
Do we have anyone?
yeah, we're gonna try here. Hang on.
So it's a little quiet. Yep, you can see the screen.
How's that?
Good. But
Okay, sorry. So my name is Ashley, and I will be presenting on behalf of my team, which includes myself, Bridget, and Riley. Our poster explores the impact of early and adequate prenatal care under healthcare access and quality. So prenatal care is defined as the healthcare received while pregnant to care both mother and baby. That includes checkups and routine testing to find and prevent adverse health outcomes. Early prenatal care can also reduce the risk of pregnancy complications and can help control existing conditions to prevent serious complications and their effects. So what is the problem? Well, not all expectant mothers are able to access prenatal care due to socioeconomic factors. The goal of healthcare access and quality is to increase access to comprehensive, high-quality healthcare services. So what are the effects of inadequate prenatal care? We found babies are 3 times more likely to have a low birth weight, 7 times more likely to be born premature, and have an increased likelihood of neonatal death in both the presence and the absence of antenatal high-risk conditions. There are several factors that influence a woman's access to prenatal care. Socioeconomic factors such as poor education and pregnancy at a young age were found to be the largest contributors to receiving late or no prenatal care. As you can see from the chart at the bottom there, women under the age of 19 account for about 35% of women who do not receive proper prenatal care, if at all. Learning this, we sought to find programs and interventions available that help address these disparities. The Maternal and Child Health Block Grant Program provides healthcare and public health services for 91% of all pregnant women in the U.S. The Maternal Infant and Early Childhood Visiting Program gives pregnant women and families considered at risk the necessary resources to raise children who are physically, socially, and emotionally healthy. Similarly, the Healthy Start Program offers prenatal, postpartum, well baby, adolescent care, reproductive life planning, outreach, and women's health to communities of racial ethnic minorities, poverty, and low education with limited access to care. There are also financial support services such as Women, Infants, and Children, or WIC program, and Medicaid for insurance purposes. All in all, our team's research highlights the importance of behavior change and communication from an interprofessional education standpoint. With a high percentage of teenagers lacking proper prenatal care due to poor education or a desire to conceal the pregnancy, the responsibility to educate the patient falls on a broader scope of professionals, such as parents, teachers, counselors, physicians, and public health workers. Having all of these lines of communication open leads to better availability of resources for the patient to ensure a safe pregnancy, both mentally and physically. So to conclude, we found prenatal care imperative for keeping mother and baby healthy, both during and after pregnancy. When pregnant mothers receive early, adequate prenatal care, they are ensured the highest quality of care and prevention for themselves and their growing baby. Thanks for listening.
Great job, Ashley. And just like many of the other presentations, I always like seeing the graphs, and it's just a huge, what stands out to me, a quarter of mothers in the under 15 age group. I mean, that's a huge jump. Even 15 and 19, 10% is inadequate, all of it, but that one really stands out. I don't know if you noticed that too when you were researching this, or maybe you already had some awareness of that.
Yeah, and most of it stems from, the desire to conceal out of shame or, just not wanting anybody to know. So they just shy away from receiving that care.
Yeah, fascinating. Thank you. That was any questions for Ashley or Ashley's team? Great job. Thank you. Thanks, Ashley. So we'll jump to Team 32, Max, Tyler, and Kelly. Their presentation, it looks at how healthcare education impacts health outcomes. So kind of an educational focus slant to this presentation. So we will turn it over to you.
All right, Brian, do you mind pulling up our poster?
Sure.
Thank you.
Yep, let me just,
All right, so my name's Max, and my other members are also Tyler and Kelly. And we decided to define the social determinants of health through an educational standpoint. And the main objective of our poster presentation is to show how the education levels of healthcare professionals greatly impacts patient outcomes. So to get right into it, I kind of want to go into how education levels affect patient outcomes through a nursing standpoint. So we know that students can become nurses through various degrees, associate degrees, bachelor degrees, and master degrees. And as you go up that incline, these students become more experienced, gain more skills along the way. And so yeah, basically that's all I want to say right there. And for a bachelor's degree nurses, they're more related to lower mortality rates in their patients compared to associate degree nurses. Then as you go more farther up to master degree nurses, they're more equipped to challenging practices, which makes them and allows them to ensure quality patient care. And then they also have a higher level of leadership skills, which allows them to cooperate more with their colleagues and their patients, and also allows them to have more organized care, to be more patient care oriented. And then going down to student burnout and how that affects patient outcomes, it is shown that student burnout leads to fewer or less positive professional behaviors, which basically puts the patient's care and health at risk. And also those students that become more burned out are more likely to undermine competencies that are needed for healthcare organizations. So these competencies would be needed in organizations to carry out missions and their values for their patients. And then going up to the top of the poster, we see this diagram. So this kind of relates to student burnout. So on the left side, you have your personal factors and those factors related to medical school training. And those can contribute to student distress, burnout, and depression. And these outcomes can also lead to potential consequences, whether that's personal or professional. So examples of that is a poor quality of life for the students, a decrease in academic performance, or a lack in interpersonal relationship. And then we also dived into ethnic and cultural diversity and how that affects patient outcomes. And I do want to start off with saying how it is projected in 2050 that half our population in the United States will consist of minorities, yet our healthcare workforce is limited in the proportion and percentages of minorities. And this is usually due to educational barriers. So typically, minority students are more likely to attend under-resourced schools, which would include, these schools would include a lack of intellectual engagements, limited opportunities for these students, and a lack in proven and effective mentors for them. And the graph below shows how ethnic backgrounds relate to health professionals in the healthcare workforce. So that blue bar in each of those, that blue section in each of those bars represents the white population, and then the smaller colored regions represents the minorities. And as you can see, like it gets to nurses, to pharmacists, and increases that, you see a more dominant white population. And it kind of shows emphasis that we need to address this issue with the lack of diversity in our healthcare workforce, because it raises problems like communication barriers between the provider and patient, and not providing enough efficient care for the patient. So going on to the solutions, I want to start off with about student burnout, in that medical institutions and programs should integrate mindful training courses, which would include the students creating coping mechanisms to reduce or lower physical and emotional responses or reactions to stress. Then there's also ethnic and cultural diversity solutions, in which we can have medical programs incorporate cultural immersion practices, which would also enhance cultural competence for these students. And lastly, to tie in about IPE. So we need a shift in education toward collaboration and teamwork dynamic, so we can be more efficient in our care and meet patient needs. And in order to limit medical errors, we also need to incorporate the ways of IPE. So without the use of IPE, we're going to continually see an increase in medical errors and lower patient satisfaction. So to sum up this whole post here, I want to say education is greatly impacts how health professionals treat their patients. But with the use of IPE and bridging the gap between levels of education, and also combating student burnouts and breaking the barrier for diversity, we can train these future health professionals to provide more efficient care and higher patient satisfaction. And that is it for our post presentation. If you have any questions, just go ahead and ask.
Thank you, Max. Any questions for Max or Max's group?
Max, I just appreciated from your poster and your team, I appreciated the tie-in between education and how education factors then play into how people become and act in the health professions. So that idea, one of your research studies that you had shared with me and was in the lower left corner of your poster, was this idea that when students are burnt out, they're more likely to plagiarize or break competencies, and that then translates to when they're in the professional fields, which then translates to patient outcomes. And I really think that's the continuum of impact in your poster. And so I really appreciated that, because that's not something that we as students always think about, right? We're just thinking about trying to get through. We always think when we get to the next level, we'll be different, or it will be different. But we forget about the fact that the patterns are ingrained along the way.
Exactly.
I was thinking about, yeah.
Mm-hmm. Oh yeah, thanks for making that point.
Kind of laying the importance of laying good foundations during your educational training, like you said, not just thinking about it as getting through, but laying good foundations in a holistic sense, not just the knowledge, but the competencies and the characteristics and attributes that you develop in your programs as well. So,
oh yeah.
Yeah, thank you. Thanks, Max.
Yeah, thank you.
So our next group is group 33, Haley, Megan, and Madeline. And they're looking at economic stability related to food insecurity for college students. So I will turn it over to your group, and certainly let me know if you need me to screen share at all.
Yeah, would you mind pulling up our presentation?
Sure.
Thank you.
Yep. How's that look?
Awesome. Thank you so much.
Sure.
Hello, my name is Megan Hicks. I'm with Maddie Thalen and Haley Lentula. I will be discussing economic stability and how it relates to food insecurity for college students. So, economic stability is described as the ability to afford basic essentials, such as healthy food. 1 in 10 people experiences economic instability. Food insecurity is the inability to have consistent access to food and affects many college students. 41% of universities reported food insecurity among their students in 2019. Urban universities face food insecurities more than suburban universities. Racial groups that experience food insecurity the most include Black, Hispanic, and Asian students, as well as members of the LGBTQ+ community, students at two-year colleges, students with criminal records, students with prior military experience, and students independent from their parents. We were also interested in how students were affected by COVID. We found that during the early months of the pandemic, 22% of undergraduate students enrolled at a large public research university were impacted not only by COVID-19, but faced food insecurity as well. Food insecurity can have drastically negative effects on students' physical, mental, and emotional health. Symptoms include a decrease in physical activity, sleep insufficiency, and an increase in perceived stress, which can lead to the onset of depression. Combined, these outcomes contribute to negative academic outcomes, such as decreased energy and concentration in class, ultimately leading to a decrease in grades and GPA. To protect students from facing food insecurity, preventive measures are needed now. Preventive care is the act of running tests, screening, vaccinating, etc., to prevent disease, medical problems, or injury from occurring before the problem arises. Our call to action includes increasing the use of multiple screenings in students to screen for food insecurity like you would screen for depression. These screenings can be done during students' orientation prior to starting classes to see if they are at risk or are already suffering from food insecurity. Our next call to action is encouraging the use of on-campus food pantries and increasing the awareness of them. Only 56.4% of students were aware that they had access to a food pantry on campus, and only 22.2% of food insecure students utilized it. Schools can also increase students' accessibility to meal plans and leave their dining rooms open during breaks. Food insecurity in college students can be related to interprofessional education through communication and teamwork needed from the university for these preventive measures to be achieved. Universities provide a safe environment. This includes the ability to challenge ideas and ask questions to provide the best care for students. Universities can also use integrative collaboration care plans to set goals around the concerns of the food insecure students. Food insecurity is a concerning problem for many students and is not receiving the attention it deserves. We hope as the problem continues to grow and studies continue to be conducted, that we see universities address this problem and take action. We'll now be answering any questions you may have. Thank you.
Great job, Megan. And we'll open it up to questions. And just a comment, this is a real fascinating topic, and I've been in education and higher education in particular for a long time, and certainly aware of this issue. But some of the things you talked about, like food insecurity screenings, you know, that's real novel, and just, I think, a fascinating idea. You know, and I was thinking about it from also the perspective of not just lack of access to food, but are students in need of maybe dietary counseling in terms of how to craft like a proper diet, you know, like too much sodium, too little iron, whatever it might be. I think all of these things, similar to the last conversation we had about laying the foundations for being an effective healthcare provider in school, some of these things, laying the foundations in college when you're out doing it for the first time is so important. So I really appreciated the topic.
I absolutely agree. Thanks for bringing that up.
Any other questions for Megan or comments?
Great job.
Yeah.
Thank you.
Yeah, interesting topic. Thanks again, Megan. We will jump to our next group, which is team 34. Kendra, Alexis, Riley, Amaryllis, and Ashley. And their topic is looking at what makes a neighborhood healthy.
If
So
you
we
wouldn't,
will turn over.
go ahead. If you wouldn't mind sharing our
Sure.
post, please. Thank you.
Yep. Look good?
Yeah, can everybody see that? All right, so hi everybody. My name is Ashley, and on behalf of my group, I'm presenting. As Brian mentioned, it's Riley, Amaryllis, Alexis, and Kendra. The purpose of our research was to examine the effects that social determinants impose on human health and well-being. From the 5 domains, our group chose the neighborhood and built environment. And we formulated our research around the question of how does the neighborhood and built environment affect the physical well-being of adults? We discovered many factors within the neighborhood and its built environment, which refers to its actual physical characteristics that may encourage or inhibit physical activity. We narrowed our focus to 5 primary influences, which include environmental factors, individual neighborhood locations, socioeconomic statuses, accessibility to resources, and the incidence of violence and crime. According to the World Health Organization, 11% of US mortality in 2012 was attributed to environmental causes alone. Some of these factors include air pollution, exposure to toxins, and unsafe drinking water, just to name a few. The leading adverse health effects from these factors include cardiovascular disease, asthma, and diabetes. Research suggests the burden of chronic disease can be reduced through participating in an active lifestyle, and it is generally accepted that exercise helps control weight, combats cardiovascular disease, and extends life expectancy, amongst other benefits. The impact of a neighborhood's location on physical activity shows that adults residing in rural areas are less physically active in comparison to those residing in urban and suburban areas, due to having a limited number of physical wellness centers, and they are also less likely to receive the appropriate education regarding the benefits and importance of physical activity in their lives. The significance of socioeconomic status and accessibility to resources pertaining to physical wellness are interrelated as well. Research reveals that individuals from lower status groups are typically less physically active, but for many reasons, which includes the possibility of working longer hours, making less income, and therefore having limited time and or the finances. Individual neighborhoods of low to medium socioeconomic statuses have less access to free health promoting resources such as open gyms, parks, or trails, as well as less access to appropriate nutrition due to these neighborhoods typically being infiltrated with more fast food options and less fresh food markets. The last factor includes the incidence of violence and crime. In neighborhoods with higher crime rates, individuals experience greater levels of fear, which in turn can cause mental health conditions such as anxiety or depression. As future providers of healthcare, it is our responsibility to thoroughly understand the social determinants that impact individual health regardless of location. To reduce the barriers that some may face due to the neighborhoods in which they reside, we could provide alternative resources to obtaining adequate nutrition, such as food gardens or possibly meal planning. Some may benefit more when given a printed guide to quick at-home fitness routines that utilize materials that they already have in their homes. Providing these simple but yet helpful tools are the smallest steps that can make the biggest impact on the physical wellness of adults across the country. Thank you.
Thanks, Ashley. Great job. And a true social, broad social determinant of health in the true sense of the word, and just neighborhoods. I think that's a real interesting topic, looking at where someone lives and how that impacts their ability for access to, or not just access, but interest in getting exercise and being active. So really interesting. I appreciate, yeah, thank you. Any questions for Ashley or Ashley's team? Yeah, great job. Thank you, Ashley. So we'll jump to our next group, which consists of Jillian, Abigail, Nicole, Karina, and Alexis, group 35. Oh, let me stop the share here.
Would you be willing to share our poster as well?
Sure.
Thank you.
And looking at influence of socioeconomic status on access and quality of reproductive health care. So Let me go ahead and share this. Zoom in a little bit. And I will turn it over to you.
Perfect. Hi, I'm Jillian, and I will be presenting on behalf of our group. The domain we chose to do our presentation on is healthcare access and quality. The purpose of this poster is to examine the effect of socioeconomic status on access and quality of reproductive health care for women. Our PICO question that we chose to research is, does socioeconomic status affect the access and quality of reproductive health care for women? Reproductive health revolves around the ability to have a responsible and healthy reproductive system. It involves having a healthy sex life and having the capability to reproduce and the freedom to decide if, when, and how to do so. When looking at sexual education, we found that reproductive health is often taught by parents, K-12 faculty members in an educational setting, local resource facilities, or it may not be taught at all. According to a study conducted by Kohler, young women who received comprehensive sex education had a lower risk of pregnancy than young women who received abstinence only or no sex education. In a similar study conducted by Stinger Hall, the more abstinence is stressed in state laws and policies, the higher the average adolescent pregnancy and birth rates in that state. Overall, low income and low education levels contribute to a higher pregnancy rates. Simple changes, including posting informational bulletins, extended clinic hours, more affordable childcare services, changes in state legislation, and expansions in policies around the United States can help improve reproductive education. In the access to women's healthcare, a qualitative study of barriers perceived by homeless women by Goldberg, the barriers that women face regarding family planning and reproductive healthcare was examined. It was determined that the most barriers that these women face are limited clinic hours, transportation, and the top two based on that graph is the cost of receiving care and the comfort level that these women had with healthcare providers. Moving on to family planning. With respect to income, 12% of women earning less than 150% of the federal poverty line were not using contraception, including birth control, condoms, and other contraceptives like that, compared to the 9% of those earning more than 300% of the federal poverty line. In a study conducted by Boonstra and others, 49% of abortion patients had a family income below the federal poverty line, which was nearly doubled from 27% in 2000. An additional 26% of abortion patients had an income that was 100 to 199% of the poverty threshold. In other words, 75% of abortions reported in this study were among low-income patients. When looking at reproductive health, the majority of women who do not receive prenatal care were those of low socioeconomic statuses. Additionally, women of low socioeconomic statuses are more at risk for immediate causes of infant mortality, such as birth defects, preterm birth, sudden infant death syndrome, and maternal complications. In conclusion, women of low socioeconomic status receive inadequate reproductive health care, including sexual education, preventative gynecological health care, contraceptive techniques, abortion resources and clinics, and prenatal and birth control and birth care. Concerning interprofessional education and patient safety, it is important to improve health outcomes for all women, especially women of low socioeconomic statuses. Any questions?
Good job. Thank you, Jillian. Any questions for Jillian or Jillian's group?
I have a question for any of you guys. How do you think this is going to impact this information? How's this going to impact you as future healthcare workers yourselves? Where do you think you can take this information and run with it?
I think just us having the platform to advocate for low socioeconomic women, I mean, let alone being able to research this poster is something that not everyone gets to do, because not everyone has an access to a computer as easy as it is this day. That's the reality that many people face. And I think just researching this topic, it's become more aware that we need to advocate for people who aren't as fortunate as us.
Great answer.
I should mention too on that topic, while I'm screen sharing here, you can see the MyPERT conference in September, all of your presentations, and there's going to be a student poster presentation section. So if any of you are interested in presenting at a regional conference, it's going to be virtual, but you can see our topic here, and it relates to kind of what Jillian just touched on, but the overall topic is responding to the needs of diverse patient populations through interprofessional advocacy, education, and research. So if you're interested, call for abstracts is now open, so you're able to submit for posters or virtual podium presentations. So certainly think about that if any of you are going to still be here next year and want to get a little bit wider audience for your posters. That would be something to take a look at. Why don't we jump to, and we actually have, I just want to make you aware, we have one group after the, so we essentially have 3 left because someone couldn't go last night. So we'll move through them. Delaney, Drew, Noah, Emily, and Cecily, group 36. And let me stop the screen share here and I will turn it over to you. And if you need me to share your poster, I am happy to do that.
I think I got it here.
Okay.
Can everyone see that okay?
Yep, looks good. Thanks, Emily.
Perfect. Oh, don't want that. Okay. So hello, everyone. I'm Emily Morell, and I will be presenting on the social determinants of health with a subtopic or specialization in developmental importance of proper nutrition in children. So our topic, basically how we decided to handle this is we sat down and figured out all the different types of social impacts that would affect children's nutrition. So for a background, unfortunately, children on average do not consume a balanced diet. A balanced diet consists of different types of vegetables and fruits, whole grains, low-fat dairy products, oils, and a variety of proteins. Eating a healthy breakfast is connected to improved memory, reduced absenteeism, and a better mood. So proper nutrition for children is very important when it comes to things like school and development. So our PICO question is, what are the social and community determinants that contribute to nutrition in children? Our group decided that that was community, family, demographic, and school impact. For community impact, there are community-based nutrition programs that are geared toward the areas of weaknesses or struggles within a particular community. And it's important that all these nutritional programs are made uniquely for each community, so it fits their specific needs. And another great thing that the community can do is have family education programs. They're an effective way of establishing healthy eating habits for children, and it also benefits the household. Our next section is family impact, and that discusses how children are exposed to their parents' eating habits, which could include their style and control, role modeling, using food as a reward, and low levels of health literacy that are linked to overall health. Malnutrition results from families of poverty due to the poor quality and quantity of foods, which would lead to impaired brain development. Next, the demographic impact section is seen through social economic status, geography, and educational level. A lot of groups touched on these, but we kind of have a different spin where we're seeing how that impacts children and their nutrition. So those with a higher social economic status have healthier food habits than those with a lower social economic status. Geographically, neighborhoods and zip codes of a lower income generally have poor nutritional habits than a higher income neighborhood. And education also plays a role in nutrition, and those with a higher education level tend to make healthier food decisions and are more knowledgeable about the importance of proper nutrition for their children. Lastly, school impacts nutrition because for many children, their school lunch is the healthiest and most balanced meal they'll eat in their entire day. The U.S. Department of Agriculture has a school breakfast program, school lunch program, and a fresh fruit and vegetable program. Children who participate in these programs perform better in school, have better behavior, and better attendance. In addition, nutritional education intervention reduced calorie and sugar intake, and it increased fresh food intake and nutritional knowledge. Our significance graphic down in the lower left-hand corner here basically demonstrates the adverse childhood experiences through their environments of family, school, demographic, and community impacts, and its influence from nutritional habits. So these nutritional habits will continue through adolescence due to the disrupted neurodevelopment, creating impairments, and then the risk of disease or early death into adulthood, depending on the severity. So basically, the decisions that you make as a child, your nutrition, your overall health, will directly impact your future, and it will cause different diseases and illnesses and that kind of stuff as you're older. To conclude this poster, we drew connections to IPE. So in healthcare, there's a growing number of health conditions such as cancer, heart disease, diabetes, and all of them stem from improper nutrition. Therefore, we need all the different social impacts above, so community, family, your demographic, and your school to collaborate and work together in order to stress the importance of proper nutrition and see a change in healthcare trends. So overall, improving nutrition for children is a team effort, and every impact on a child's life makes a difference. And then we have our references page too. That's all.
Great job, Emily. Yeah, again, as we've mentioned earlier, too, a really, really important topic. And one of those that it seems like if hunger and nutritional needs are met, there are so many more opportunities to soar, but it's such a foundational, important level of need for so many kids. So I really appreciate that you and some other groups touched on that this evening. So any questions for Emily or Emily's group?
I would just like to add to that. And moreover, I think this is another thing that as professionals going into the field, we have to think about how these habits start in children. And so as we see our patients as adults, often that's the majority of our population that we treat. We do treat some kids, of course, but if you look at the span of people you're going to treat, it's usually the majority adults. And thinking about what happens for them early on in their lifespan and how those habits become ingrained. And this isn't about nutrition, but it reminds me of my mom. And my mom is a smoker. And a lot of practitioners would like to look at her and say, why don't you just quit? All these other things would work for you in your favor. She started smoking in 5th grade. Oh. She's 68 years old, and so you recognize the impact of her childhood experience, tied into the neighborhood effects. She also, you know, lives on jujubes and all sorts of unhealthy nutrition, and her mom did too. Her mom was real thin and smoked, and that's how she maintained her nutrition. It was, are you hungry? Well, I don't want to be fat, so I'm going to smoke. And those patterns are laid by parents as well as what's allowed in the community. So it just kind of all ties in together, not just for nutrition, but all over lifestyle habits.
Absolutely.
I really like the way this is all, the night's coming together. It's got me all excited.
I agree. Yeah, great topic. Thank you. Thanks again, Emily.
Yeah.
So our next group is group 37, Grace, Stephanie, Ryan, and Madison. And they are looking kind of a similar type of topic, impact of economic stability on nutritional well-being. So we'll see what they have to add to the conversation.
Yeah, would you mind sharing our poster for us? Awesome, thank you.
You know what? It might take me just a second here because for some reason I didn't have that one linked. Give me a second though, because I think I've got it. You beat me to it. I got it.
Perfect, thank you.
Yep.
Okay, so I'm Ryan. I'm here with Grace and Maddie, and we're going to be presenting our poster on the impact of economic stability on physical well-being. So just a little bit of an introduction. Food insufficiency is when there's an inadequacy in the amount of food intake because of the lack of money or resources. 3% of all households with children and 7.5% of low-income families with children experience food insufficiencies. A little bit of background, a food desert is a geographic location where people's access to affordable, healthy food is limited or even non-existent due to the absence of grocery stores within a convenient traveling distance. Also, the inaccessibility and increased food prices lead to families being forced to choose unhealthy and more affordable options such as fast food.
Okay, and then I'm going to talk about the graphic that we have just a little bit. I know it's kind of hard to see, but it says in 2009, 2.3 million Americans lived greater than 1 mile away from a supermarket and didn't have a car. So just to kind of put this into perspective, 2.3 million Americans is about 2%, or was about 2% US at the time. This was in 2009. And a lot of these that were like
I think we might have lost Maddie. See if she's able to get back in. If not, one of the other group members want to jump back in. Ryan, you want to?
All right, I was not able to hear where she left off at, but a few of our interventions, obviously, we want to look at ways that we can moderate these effects of food insecurity, like the poor health outcomes. So the first thing is implementing fresh produce options. We know that food choice is directly driven by prices and access. So local farmers markets, and even incorporating fresher food options into existing grocery stores to increase access, because we're seeing in these regions that are defined as food deserts, we're seeing high obesity rates, higher rates of chronic disease, and poor school performances for school-age children. And then secondly, our team talked about physical and mental wellness programs. And during our research, we found that nutrition education increases healthy food access and consumption. Now, ideally, we want to prevent these chronic diseases and other poor health outcomes before they occur. So our team is all pursuing careers in nursing, physician assistant studies, physical therapy, and respiratory therapy. So not only is one solution increasing access, but something that we can do as future healthcare providers is to emphasize, these preventative measures and education, because like we talked about, a lot of these habits develop when we're young. And so providing resources and education that even if, the older generation has had these, unhealthy habits because of like inaccessibility, they can pass this down to younger generations. And that's something that we can do as future healthcare providers to really make a difference in our communities facing these food insecurities and poor individual health outcomes. So thank you to everyone who's stuck around towards the end here. Is there any questions?
Thanks, Grace. Yeah, thanks for picking that up too. Any questions for Grace or the group that just presented?
Well, and Grace, I just want to say, as we think about being providers, like you mentioned, then perhaps we can advocate for further incentives too for providers to go that step further. Because oftentimes they're available for advice for their patients, but they're not always able to, just by the sheer time and how our current system works, to pursue further with their patients for resources and advocating at a deeper level. So
Thank you. Yeah, great job. So we've got our very last group, which is actually Team 7 on the website, and impact of healthcare access and quality of life. So I will turn it over to our last group, and if you need me to share, let me know, but we're excited to hear what you have to talk about.
Yes, can you share it for me, please?
Sure. Yep. Okay.
Yep, looks fine, thank you.
Yep.
Hi, so my name is Carlicia Thompson, and I'll be representing my group, which consisted of Madison, Kaylee, Abby, and Grace. Our group poster is on the correlation, if any, between underserved communities and a decreased quality of life. Through our research, we found that the amount of people living in underserved communities are more than double the amount of people who are uninsured. These people living in these areas are at a higher risk in developing diseases such as obesity and cardiovascular disease, which until recently was the #1 cause of death in America. Residents in these communities have less access to quality health care because of barriers and disparities such as language, financial, and proximity to care. For instance, I currently work in a nursing home, and I've had multiple times where I've had residents with super thick accents or that come from different countries in Europe and stuff, where we couldn't barely understand what they were saying. And not only is it frustrating to the caregiver, who also takes care of 16 to 17 other people, it's also frustrating for the residents and their families, because how can you help someone if you can barely understand what they need or are having a problem with? So there are millions of people in the United States who are uninsured, and that has only increased when people lost their jobs due to COVID. Majority of Americans receive insurance through their jobs, so no job means no insurance. These problems lead to increased mortality rates and a decrease in quality of life. Addressing these disparities is one of the first steps in bridging the gap between the people who live in these communities and the people who work in the medical communities. Right now, people are doing everything they can so they don't have to go to the hospital. They have to consider, can I afford to go? Will I be treated fairly? Will I be seen in a decent amount of time? Is it worth going? Will they understand me? Will I be penalized for going to be seen by a doctor? I've worked in multiple nursing homes across Grand Rapids, and A lot of them where I worked did not accept a doctor's notes. So if I had to call in or I had to go to the emergency room or see a physician for any reason, I would be penalized because there is no excuse absence for getting help and getting care that you need. So in conclusion, about 67 million Americans live in federally designated healthcare professional shortage areas, or HPSAs. So the next step is to figure out how we solve this problem. How do we fix the provider shortage and increase quality of life in these communities? As we discussed a little bit earlier, we can start with more scholarship and incentive programs in these communities, and also early and repeated exposure to those areas for medical students. So that's our poster on the correlation between underserved communities and decreased quality of life.
Thank you. I appreciate how you incorporated some of the importance of debt that, I mean, across the board. I mean, this can be true for nursing students, PT, OT, MPH, all the way through physicians, and how important that burden not being there can be to being able to feel free to practice. So again, as I mentioned, I was in medical education for about 10 years. And it was interesting because the mission of the school I was at was very focused on service to underserved communities. And so we'd bring in students often that had really altruistic values for where they wanted to serve and how. And some really held true to that through medical school, but oftentimes you would see salary and ability to pay medical school debt impacting those choices in major ways, and students kind of steering their choices of residency and ultimately where they practice based on that more so than some of their values. And part of it just had to do with sometimes making practical decisions. So I liked how you put some bullet points about scholarship and incentive programs, because sometimes that can make a huge difference in where people choose to practice and how. So yeah, great presentation. Any questions at all for our last group? No? Or any final comments?
Great job, everybody.
Great job, everybody.
Really impressed.
I agree. Some real excellent presentations, and we won't hold you up anymore because I know we've gone over, but I think it was really important to give everyone time to present. I think for many of you, it was probably your first opportunity to do this in a professional setting. And so it was a real great experience to both do the research and then be able to present it. And I hope many of you carry not only the research and the topics that you did with you forward, but learn something from the other folks that presented. And that's really the importance of these kinds of sessions, is to kind of get snapshot research such that you can take that with you as you go forward. So really appreciate everyone sticking around and being very attentive, and really excellent job. This poster is going to, website is going to be live on the IPE office website under events. It's live there right now, as you know, but under the events tab, you can see the tab for the Health Expo in case you want to refer back to it at all or link it to some kind of virtual portfolio. So again, great job. We hope you have a great rest of the evening. And on behalf of I was going to say on behalf of the other faculty that are on the call, we just really thank you for all the excellent work that you did. So, thanks guys, and we'll see you next time.